Oh, there's literally a hole in it. I know. Thank you.
Blowing balloons up with him out.
I'm dead. They said we need these now. Right. Okay, that works. And then we're gonna do the panels on moving.
How many balloons you can be? I know. I'd be punished.
Pride on Sunday. I know it's not the parade, but
I literally don't care.
same at this point. Yeah, I'm like, Well, we could see. You said in like 9:15, and like I can pick it off by 9:15. I know that one on the end is for us, and then the two are for the speaker. Yeah, I don't think so. Yeah, we can take it off.
Good morning. If you can hear me, clap once. If you can hear me, clap twice. Y'all are good. Y'all took two. Wonderful. Welcome, everyone. It is 9 a.m. As those of you that know me, I always like to have a very packed agenda for some reason. So we are starting promptly and are going to try to stay on our timeline for today to make sure that we get you out on time, 4 p.m. at the latest. I just want to welcome everybody for being here today. We have been doing this conference for 29 years now. And this is our second year providing this conference really for individuals who are working in peer support roles or the employers of folks working in those peer roles. And so we're really excited to have so many people here today. We had a very full registration, which for us was a good sign. You know, we've been working directly with a lot of you for a couple years now, and so it's nice to see all of your faces here in the room together. So I'll do some quick introductions to kind of who we are, what we're doing today. As many of you know, we are from an organization called Cal Voices. We were founded in 1946. We are the oldest consumer-run advocacy agency in California. Peer support is what we do. So 100% of our staff identify as having lived experience, from our volunteers and interns all the way to our executive director and our board members. So it's not something that we just talk about. It is something that we really do live and breathe. And so we're really excited to have you all here. We've been doing this work statewide for a long time, and it's nice to be able to have you focus on a county to provide more comprehensive support to those of you working in peer roles and those of you employing them. Our program is so long. The Certified Medi-Cal Peer, no, that's not it. What is it? It's the Certified Peer Support Specialist Leadership Liaison Program. It is a mouthful. And we are really set out to expand the peer workforce here in Sacramento County, expand the knowledge that our employers have so that we are hiring the right people, supporting people in the right way, utilizing peers in a way that we know aligns with the evidence-based practice, and providing that extra support for peers in the county to get your continuing education, to get coaching, all of those supports that you may need, and really kind of setting off in your career or expanding in your role, advancing in your role as a peer. And so we're always excited after all of our trainings and our TA sessions and our listening sessions to be able to have everybody able to come together and have that opportunity for cross-learning. And so we hope we'll do that with each other today. So our conference this year, as we mentioned, is for peers, for all of you, for our employers. And so again, having everyone in the same room is not something I think we get to do very often. So I really want to encourage you to network. How many meetings do you go to that are in person outside of your agency? Yeah, not a lot of hands anymore, right? So back in the day, pre-pandemic, we had business cards, and we would hand them out to each other, and that doesn't really happen very often. And so I want to encourage you to do that today. Meet people who are doing similar work as you. Meet people who might be doing something that you're interested in. Get their information, and really, let's get back to networking. Our theme for this year is about building community, and so let's try to do that while we're here today. And we're going to briefly go over our schedule. After my time up here, Dr. Ryan Quist will provide some opening remarks to us. We will have a panel discussion focused on integrating peers into clinical teams and programs. And we'll follow up with a break. If you've noticed, there's been a lot going on outside on the patio. We have cornhole, we have the Giant Connect 4, we got a giant Jenga out there, we have a photo area. So we really want to encourage you to utilize your breaks and do something enjoyable. After our break, we will have a guest speaker, Vesper Moore, who is visiting from Massachusetts from the Kiva Center. Some of you might not know the Kiva Center actually was started by Pat Deegan back in the day as a transformation center. So they have a lot of history, and we'll be able to come and share their knowledge and experience with us. We'll then have a lunch break, and we are going to make it way more smoother this year, just you watch. So we have a plan. Following lunch, we'll provide some program updates, things that we have going on in our program, new things that we want to share with you. We'll have an additional panel discussion on how we can utilize peer support to really engage more diverse communities or communities that wouldn't typically engage with our traditional system. We'll have a break. And then we will be welcoming Ebony Chambers Clinton, which I believe a lot of you know. She's from Sacramento, has been doing a lot of great work statewide. And she'll really kind of pull the day together for us in her afternoon talk. And then we will close up with a raffle and some closing remarks. So we have a lot of great raffle prizes that were donated today. And you'll have an opportunity, hopefully we'll pull your number and go home with a nice surprise. So quick housekeeping, restrooms are out these two doors. If you go out to the left, there's a women's restroom. If you go out the right door, there is a men's restroom. Parking, we were hoping that folks would park in lot 8, which is kind of out here in front of the Alumni Center. You didn't need to buy a parking pass or anything. Our staff should have asked you if you parked in the parking lot, so we will cover the parking fee after. As I mentioned, we'll have 2 breaks in a lunch period. Lunch distribution, we are going to have folks that pre-registered get in line for lunch first, and then we'll ask folks if you were on the wait list, if you were added late, if you got an email from us that was like, hey, can't guarantee which meal, we're going to have you wait just so that we can make sure folks get through who are able to do their meal selection early in registration. We also have a, Robert, you want to hold that up for me? You'll see these around the room. It says guest pics. Anybody gone to a wedding where they were like, take a picture of this and you can upload all your pictures? Anybody? Some people don't know what I'm talking about, some people do. Okay, so these QR codes are around the room. If you click the QR code, it's gonna have you put in your name, and you can start uploading photos from today's event. So that way everybody can kind of go through, look at the gallery. It won't be a picture that kind of goes into the universe and you're never able to find again. So we'd love to find your nice Kodak moments. And so please go ahead and take advantage of that. They are around the room. If you need to find one, let us know and we'll make sure you get that QR code. On your tables, you have a bucket of, we like to call them wellness tools. So there are color pencils. There's actually little mini coloring books in your bags if you like that. There are little, are they widgets? Is that what we call them? Fidgets, thank you. In the bowl. There are a lot of things to keep your hands busy. We know that, I don't know about you, it is very hard for me to sit for a long time and especially listen to other people talk. So we want to invite you to engage in activities that can help you stay present. We do have centerpieces in the middle. Those were actually developed by Sustainable Wellness Solutions, formerly Consumer Self-Help Centers. Thank you. And they were able to put these together in their art groups. So we're really excited that their groups came forward and were able to provide those centerpieces for us as well. At the end of the day, we're going to ask you to complete a conference evaluation. We really did take a lot of feedback from last year and made some adjustments for this year, including making sure that we have full non-activity break periods. And so you will have a little bit more time for yourself to step away and take a break as needed throughout the day. And then lastly, we will email out certificates of attendance after the event, likely in the next week or two. So keep an eye out for those as well. I'm trying to think if I'm missing anything. I think that might be all. So I am going to invite Dr. Ryan Quist up. Those of you who might, I feel like everybody should know Dr. Quist. Everybody should know Dr. Quist. And if not, Ryan is actually the behavioral health director here in Sacramento County. He actually started in Riverside County and has been working for over 20 years in county behavioral health. So he comes with a long history, has been a leader with the California Behavioral Health Directors Association, was selected in the CalAIM Behavioral Health Stakeholder Work Groups, and has contributed to planning for various behavioral health CalAIM initiatives that are now being implemented. His focus is on mental health and substance use services for homeless population, criminal justice population, health and substance use services for homeless population, criminal justice populations, and bolstering the crisis continuum of care to prevent psychiatric hospitalizations. And in the children's system, he's dedicated to promoting field-based and school-based services and collaborating to support the foster youth and probation populations. Ryan has been around for quite a few years now and is really leading us in this behavioral health transformation that we are all going through as we transition to the MHSA to the BHSA, and has been really dedicated and supported in getting peers also employed in the county. So we've seen a lot of change happen since Ryan has come to the system, and so we're really grateful to have him. We want to welcome him up, everybody, as he shares his message.
All right, good morning, everyone. So great to see so many of you. Excited to be here. This is May. Just want to take a moment and just acknowledge May is Asian American and Pacific Islander Heritage Month. So it's an opportunity to celebrate Asian and Pacific Islanders in the United States. It's a very comprehensive term encompassing the entire Asian continent and the Pacific Islands of Melanesia, Micronesia, and Polynesia. And so during Asian Pacific American Heritage Month, we get to celebrate the achievements and contributions of these important members of our community through festivals, various activities, and educational opportunities. So we're at the end of the month, but hopefully you had an opportunity to take advantage of some of those. This is also Older Americans Month. Also, note it's Foster Care Awareness Month. This is an important month for a lot of the things that we're. The other one I want to highlight is one of the newer, yet not so new anymore, trends across the nation is also commemorated as this is National Treatment Court Month. And so for those of you who have ever been involved or associated with any of those programs, it's a growing program. There are now more than 4,000 treatment courts in the U.S. and really represent an amazing collaboration between both behavioral health as well as our partners within the justice system. Everybody from the actual courts themselves, judges. We have an amazing Judge Brown here in Sacramento County that is an amazing partner. And then, of course, we work very closely with our public defenders, district attorneys, probation, in order to really help and support people as an alternative to, of course, jail or other punitive consequences. So I think that's another great thing to commemorate and just think about at the moment. You know, there's so many things going on in May. I could literally go on for about another 10 minutes. I do want to highlight a couple other dates. May 17th was International Day Against Homophobia, Transphobia, and Biphobia. And then, of course, Mother's Day was this month. And so thank you to all the mothers in the room. And we get a chance to also just thank our mothers ourselves. But, you know, the main one I wanted to get to, though, of course, what else is May?
Mental health.
Mental Health Awareness Month, right? So this month, some of the things I've been sort of reflecting on and sort of trying to get a message out there is that, one of the things, we've seen some amazing improvements in stigma around mental health. And I think we can really, to a large extent, attribute that and give credit to MHSA. Over the years, it's now 20 years that we've had MHSA. 20 years ago, to hear community talk about mental health, it's like pulling teeth. We would be the ones, as the workforce that works in mental health, we would be the ones educating community about what mental health is. Now mental health is on everybody's lips. We're hearing everybody talk about it, and everybody is, promoting the awareness of mental health. And we've seen an amazing reduction in the amount of stigma there is around mental health. We can see that extremely evident in the fact that we have high school students who actively generating conversations about mental health where we're not trying to draw out this topic for them. They're actually generating this information on their own. I don't know about you, but when I was in high school, I don't think I ever heard the term mental health. And now we have young people who are, graduating, going through their entire high school careers and having that as a regular topic for conversation and a regular topic to check in with their peers as well as their adult mentors within their school environments. So that's an amazing change that we've seen. And we hear a lot about it in the media, right? There's a lot more. So one of the things I've been reflecting on this year for Mental Health Awareness Month is we have seen so much improvement, but we still have so much more improvement to make. And right now, I think one of the fundamental things we are sort of battling with is that in the public dialogue, a lot of times mental health and homelessness are getting conflated or combined with each other or confused with each other as if they're the same thing. And by all means, we recognize that there are definitely connections between mental health challenges and being unhoused. We recognize that. But the fact of the matter is that's not all there is to it. One of the messages I've been saying is, I do recognize I live a fairly privileged life and I have a house. And if I lost my house today, I guarantee I would have mental health challenges. Guaranteed, right? That would just be one of the most stressful things I could possibly experience. Also, I have to also reflect on the substance use side of things, because a lot of times substance use is also getting conflated with all these, right? You have mental health, substance use, and homelessness all getting conflated together as if they're all the same thing. The fact of the matter is we know from talking to individuals who are unhoused that sometimes substance use is actually a strategy that's being used in order to help maintain their safety. If you talk to an individual that's, that you might hear, especially from women, that it's not a safe place to be on the streets and living unhoused. And so the extent to which methamphetamines, for example, might be used as a strategy in order to stay aware and safe in that sort of environment, it becomes sort of a tactic and a strategy that's almost functional. And so to think that all we have to do is take somebody, give them treatment, and now suddenly everything's going to be fine, that's simply not the case. Because now more than ever, especially here in Sacramento County, we recognize that what's the problem? It's affordable housing. We just simply don't have enough affordable housing. Here in Sacramento County, rent is 42% above the national average. And I bet you all are aware of individuals who are working, and it's not easy to get housing even with a job, let alone if you're unhoused. How do you find that opportunity to find that safe place to live that you can afford and take care of your family? That's something that's so fundamentally difficult. One of the other stories I've been sort of contemplating and sort of talking a little bit about is we had the opportunity, Sacramento County in December, we implemented Care Court just like all 58 other counties. And we had some misgivings around what Care Court was going to look like and how it might work. But I'm actually feeling pretty good about how Care Court's getting implemented here in Sacramento County. We know that the court cannot compel anybody into treatment, and so this is turning into another opportunity for us to become aware of individuals within the community who need mental health or substance use treatment, and they just weren't known to us as the system. The system was not aware of them. How can we serve somebody who we don't even know needs our help? And so this has become a new way for us to become aware of individuals who are in need of our help. And of course, that's what we're there for, right? When we know somebody needs our help, we want to help them get those services. So we implemented in December. Was it this month? I think it was either this month or just end of last month. We had the opportunity for state of California, the Secretary of Health, Kim Johnson, and her team, including Deputy Secretary of Health for Behavioral Health, Stephanie Welch, reached out to my team and wanted to have an opportunity to come and see what Care Court looked like in Sacramento County. So we took advantage of that opportunity. We wanted to show them everything. So we took a full day and showed them everything we took them to the courts. We took them to some of our safe stay communities that are funded by the state through the Behavioral Health Bridge Housing. And we sat down and had some conversations about what are the successes and what are some of the challenges with implementing Care Court. And so as a part of that, we had Secretary of Health, Kim Johnson. She was able to come into court proceedings and actually observe court proceedings. And I think she saw a really powerful example of exactly the type of challenge that individuals who are unhoused within our communities are experiencing. There was one gentleman, which I'm going to be very careful not to share any individual information, but I think the story resonates across multiple people, not just this one gentleman. The gentleman was in court as a part of the Care Court proceedings, and the judge asked him, have you tried using psychotropic medications? Because for Care Court, this is really the inclusion criteria include schizophrenia and other psychotic disorders, right? And so this individual had some sort of diagnosis within that general ballpark, and was experiencing various symptoms of psychosis. And so the judge asked him, have you tried psychotropic medications? And what he said was, yeah, I've tried them, but the problem is they make me drowsy. And I can't, because when I'm unhoused and living on the streets, if I'm drowsy, I might wake up to getting beat up and end up getting injured as a result of the side effects of these psychotropic medications. And he told a story about that's exactly what had happened to him, where he was significantly injured as a result of having been too drowsy because of his medications. That was such a powerful story for the Secretary of Health to hear, that this isn't just an individual that's, he's aware of what his challenges are. He even said, I made a choice that I'm not going to take psychotropic medications, and I'm going to recognize, I'm paraphrasing, I don't remember if this is exactly what he said, but I'm just going to recognize that those voices that I'm hearing are not really there, and I'm just going to have to live with that, because I can't afford to take those medications and then be to the point where I'm not safe in the community. He used all sorts of different words in that, but you get the general gist of what the message was. And to hear that sort of a story where this isn't just somebody who is unaware of their mental health challenges or making choices that are these are functional choices. This was a smart choice. In order to help himself be safe, he was trying to avoid getting onto a psychotropic medication that would put him at risk. Well, we did work with him. We got him into a safe stay community. So now he is living with a locked door. He's safe, and now we can begin getting him the medications he needs and get him the treatment that he needs and help him move towards his forever home. So that's the sort of story that we were able to tell. This isn't just individuals that are, they really need someplace safe to live. We need affordable housing. We need to continue to tell that story and help everybody understand that this isn't a simple story. Every single individual who is unhoused continues to have their own unique circumstances that got them in that situation, as well as their own unique circumstances that need to help them get out of that circumstance. So join me this year, May is Mental Health Month, and helping get the message out there. I know you guys all do, because that's how awesome you are, but keep getting the message out there regarding the importance of mental health and help dispel myths around what people think about mental health that just simply isn't true, and that things aren't as easy or as simple as some people think that they really are. So help me with that message. And so thank you all for that work that you do there. So I did get asked to talk a little bit about some of the other late breaking, there's been so much change over the last couple years. I did a slide where I put every single new initiative over the last 2 years, and it was so many words that it was like such small font that you couldn't even possibly read it, but it was just amazing how much change there has been over the last couple years. And thank you to all of you and your work in coming along on the journey of all this change that we're implementing across California, and especially here in Sacramento County. As everything from, I was just talking with a member of the conference around the Prop 47 program. Everything from that to behavioral health bridge housing, which we've already mentioned, care court, all sorts of SB 43. SB 43 turned out to not be quite as bad as we expected it to be. So thanks to everybody who was an advocate on that topic. But it turns out we're not seeing that many people who are getting 5150 just due to a severe substance use disorder. Turns out we should have known all along. If you have a severe substance use disorder, you probably have a co-occurring mental health challenge. And so what's really happening is we're still seeing the same folks with co-occurring conditions be the ones that are getting involuntarily held as a result of that. But the next one, and I know it feels like it's been an eternity since Prop 1 passed, and we know that Prop 1 doesn't really go into effect until July 1st, 2026, right? So we still have just over a year before we really need to implement Prop 1, or Behavioral Health Services Act, BHSA. It's coming though. So where are we at in that progress? And I know there's been lots of questions around when are we going to do the planning process? When are we going to have an opportunity to get our voice in there? So where we're at is that, Prop 1 was written very hastily, very rapidly. And there were a lot of unanswered questions around the specifics of that law. And the law acknowledged that there were a lot of unanswered questions. And so the law actually said that as a part of its implementation, the State Department of Health Care Services is going to be responsible for generating secondary guidance, basically to answer all those unanswered questions. So the State Department of Health Care Services has been going about a very rapid, yet also it doesn't feel as rapid because we want the answers now, right? But they've been rather quickly going through all the unanswered questions and coming up with answers for those. And they are issuing the answers to those questions in modules. So far they have issued and finalized Module 1 and Module 2, and we're expecting within the next couple of weeks, Module 3 to finally be finished. And that's the point where now we're going to be ready to start getting ready to come to community and start talking about implementation of BHSA. So over the next couple months, keep an eye out. We're going to have lots of opportunities to be able to come and learn about BHSA implementation, as well as an opportunity to give feedback around BHSA. You've probably heard this before, but just to continue to remind, BHSA did not bring any new funds to services. Instead, what it did is it took the existing millionaire tax, right? All millionaires, everybody who makes $1 million or more per year, has a 1% income tax that they pay to the state, and then the state disperses those funds out to counties to implement what formerly was MHSA and what's going to be BHSA. There's no new money. It's the same amount of money. What it did is it took the old 5 buckets of programming that were required and changes it into 3 buckets. One of which is housing, and that's 30% of the funds have to go towards housing. So that's the big one. And then, of course, if you sort of do the math, as everybody knows, doing your own personal household budget, right? When you're paying your bills every month, if you have to pay 30% more to something you didn't have to pay for before, that means that money has to come from somewhere. And so it's not going to be quite the same as when MHSA was implemented. I don't know, how many people were here when MHSA was first implemented? Anybody? All right, yeah, I was here too. All right, yeah, I was here too. And at that time, we were implementing something new with lots of new funding for a lot of new programs. That's not going to be what's happening this time. This time, we're going to really have to be prioritizing and be thinking about it. And one of the things I was asked to sort of mention is, where do I see peers going forward into the future? For Sacramento County, peers are absolutely fundamental to the work we do. And I've been on a mission to constantly increase the presence of peers throughout our service delivery system, whether that's as a part of our county employees, as well as a part of our contracted service providers. And I don't see that changing. BHSA is not going to change that. Peers are just fundamentally important to the implementation of community-based behavioral health. And that needs to be both on the mental health side, and if you've been paying attention, Sacramento County has also been promoting it as a part of our substance use and prevention and treatment programming as well. And we're going to continue to see that happening. I think the main themes that we all have to recognize now, okay, so, Prop 1 was coming up, and we did a lot of advocacy around where you're trying to change it or shape it in the way that we thought it should be. Well, now that's done. Now Prop 1 is what it is, and BHSA is what it is. So now we are going to basically adjust what we need to in order to continue to be honest, the thing doesn't feel good, but you sort of have to adjust to, I don't want to say chase the money, but you need to adjust your activities in order for it to fit within the allowable and fundable uses of the new BHSA funding. But you know what? That doesn't mean we have to give up on our core values. And our core values are that peers are important to this work, and the entire point of behavioral health services is to promote recovery and resiliency within our communities, right? So we're going to have to adjust what we're doing, but we're going to keep our core values and make sure that we're going to make sure that we can get the funding that we need for the activities we're doing, but we're going to have to make some adjustments around how we're doing that. But we're going to keep that dedication to recovery, all right? And I think your voices are extremely important in all that. And it is every day that you come to work. And for employers in the room, every day you should be listening to your peers when they are giving you advice on what is the best way to approach any sort of business decision, any sort of treatment decision around how you can best promote recovery, both within the individuals you're serving as well as within your organizations. And so that's going to be something that we all just need to keep really high in our mind, is that is still our dedicated purpose in delivering these services. Now, strategically, what are some changes that we might see? I'm not sure, it's always hard to predict, but we know that BHSA Prop 1 explicitly, very obviously, is promoting Medi-Cal billable services. Good news is we have peer certification, so we can bill for peer services. But there were some things we were doing before that weren't always billed as Medi-Cal services. So we just have to acknowledge that there is a fundamental incentive throughout BHSA that we need to get as much Medi-Cal as possible. The more federal dollars we bring into our communities, the more resources there are for everybody that needs those resources. So that's something we're going to have to really think about. I think in terms of crystal ball, sort of idea. I think we all have to make some strategic adjustments around the work that we're doing, and that might look like peer-run organizations actually developing a full Medi-Cal program. We've seen that in substance use programs. They're fundamentally started out as peer-run organizations. They were individuals who had lived experience with substance use and got certified and created entire agencies in order to deliver services. Along the way, they had to hire a couple clinicians or a doctor in order to help pull down those Medi-Cal services. I would predict that I think there will be some peer-run organizations that move in some of that direction, where they might still maintain their dedication to being a peer-run organization, but also hire and bring on other clinical, the LPHAs, what is that, Licensed Practitioner of Healing Arts, basically clinicians, other LCSWs or LMFTs. I think that might be something we see. The other thing I think will be interesting, and get my crystal ball out, is there's this new Medi-Cal benefit in the state of California for the clubhouse model. I'll be honest, I don't think a lot of us have figured out how to make the clubhouse model work within our existing communities. I bet you that's an awesome opportunity for some of our peer-run organizations to really get down and study what clubhouse model looks like and how we can make it work in the way we want it to work. We recognize clubhouse model has some really great strengths in general in its traditional format, but we also recognize it's a little bit different than the way we have done some of our community wellness centers in the state of California. And how can we find that middle ground that's going to be best for what we want to do in California or here in this Sacramento County? And then finally, behavioral health housing interventions. It's time for us to also be integrating peers through the implementation operations of all of our housing interventions. So I would welcome peer-run organization also think about how they can really focus and emphasize housing interventions and be part of implementing those programs. And I think I ran over time. So thank you all. Enjoy your conference. 29 years, can you believe it? Thank you all.
Thank you, Brian. We appreciate you being here. We always love to have our county leadership come and represent. And I do want to mention something. Ryan mentioned clubhouses. Hope Cooperative used to have a clubhouse prior to the core program. So if you're interested in that model or learning more, great agency to reach out to. They were having a clubhouse model for quite a while. So, we always like to say network, make friends. Definitely we have experts in the room around some of the changes that are going to be taking place. So we really want to encourage everybody to get to know one another.
Can you tell me the name of that? Who did you say?
Hope Cooperative. Hope Cooperative, yes. And they are here today. So, as I said, make some friends. It's going to be a good day. So we are going to move into our first panel discussion. I also realize I always start doing things and never tell anyone who I am. My name is Stephanie Ramos. I'm the education director at Cal Voices. I started as a youth advocate almost 20 years ago. And have worked in a lot of different peer programming, right? And so if you see the youth advocates that we have here, like that started over 20 years ago, and they have kept it going and kept their committees going and like really stayed on top of everything. So our peers have done great work in this county for a very, very, very long time, and I feel very grateful that I have stuck around to be able to see kind of like where this is all going. I am also going to welcome Robert Salinas. Robert Salinas is one of our peer support specialist liaisons. And so Robert does a lot of our training, TA, support for our employers and our peers from the perspective of a consumer peer working in the adult system. So Robert comes with his own experience working in peer roles, managing peer roles, also comes with his own recovery. And Robert is going to be our MC for this next panel. And as Robert comes up, I'm also going to invite up our panelists, and then Robert will do some introductions and then jump into our panel questions.
Good morning, everybody. Also, we're in a are, we had forgotten to put out there are bananas and what, tangaloos? Yes. Cuties on the table.
And there's creamer.
And there's creamer feedback. Yes, good. So welcome. And our panelists, we could have our panelists come up to the front here. Alicia. Yeah, Alicia Dotree, Shonda Jones, Leticia Pierce, Ashley Saunders. And I would give our introduction as to who they are, and Stephanie will tell you a little bit about me. I've been with Cal Voices about 5.5 years. Started out as working with a friends and family coordinator, and then went to the direct services as a peer support specialist, then a peer manager, and now I've been with the peer leadership liaison program for just over 2 years. So enough about me. So Alicia Dotree is a trained peer supporter and community health advocate who credits the peer community for her lived experience rooted in ancestral connection in altered states, for guiding her growth, humility, and ability to hold space for pain. She co-leads the lived experience integration team with UC Davis Early Psychosis Intervention Calibrated Network and develops, reviews, and presents trainings statewide. Alicia also serves as a peer supervisor for UC Davis's EDAPT Early Psychosis Clinic. She challenges the depoliticization of mental health, emphasizes the role of generational trauma, environment, and systemic oppression. Through her work, she fosters critical conversation about equity in care. Alicia holds a BS in psychology and is pursuing a master's in public health focused on communal care and health equity. Thank you. And a little bit about Shonda Jones is a clinical program manager of advocacy at Heartland Child and Family Services, advancing from family advocate through innovation and impact. She created Coffee Time, a caregiver group, and led a youth anger management program to support healing. With a background in education and youth development, her journey has been shaped by grief, single parenthood, and resilience. Shonda leads with empathy, striving to simplify systems, empower others, and be the advocate she once needed, with a focus on intentional, transformative care. Thank you. Leticia Pierce is a bold leader, mental health advocate, and change maker dedicated to serving marginalized communities with compassion and intention. As a program manager of Hope Cooperatives Incorporated Core Wellness Center in Sacramento, she leads a peer-driven team focused on mental wellness, housing support, harm reduction, and community empowerment. Her work centers around healing, equity, and real-life transformation. With personal lived experience and professional expertise, Leticia is a voice for those often unheard. She is known for building programs from the ground up, mentoring future leaders, and showing up for her community in a meaningful way. Whether she is managing crisis situations, linking members to resources, or empowering her staff of peers, she brings transparency, heart, and a vision of lasting change. Thank you. Next, we have Ashley Saunders, is a peer support specialist at River Oaks Center for Children, with over 4 years of experience supporting youth in their mental health journey. Her passion for this work is deeply rooted in her personal lived experience navigating and overcoming mental health challenges as both a youth and an adult. Ashley knows firsthand how essential it is to feel genuinely heard, supported, and understood. She is committed to creating safe and affirming spaces where youth can be themselves, explore their experiences, and build resilience. Passionate believes in the power of connection and is dedicated to walking alongside her clients as they find their voice and take steps towards healing. Thank you. Okay. I appreciate you all being here, so let's get into the questions and share some information with our guests here today. First question is, can you give us a brief description of your organization, who you serve, and the types of services you provide? And these microphones should be on. If you can just go down the line, that'd be great.
Okay. Is this on? Okay. Awesome. Great to see everybody here this morning. I'm Alicia. I work at UC Davis right now. I'm a peer supervisor at their SAC EDAPT clinics. It's 2 clinics in one. I'm there, it's a coordinated specialty care program, which I'm not sure if anybody's familiar with the CSC model. I wasn't when I got hired. CSC models work specifically with what they consider early psychosis experiences, so anyone from about the age of 12 to 30, I believe is our cutoff is for CSC program. So that's where I work as a peer supervisor, and I'm also on the EpiCal Training and Technical Assistance Project Network. It's a TTA for all of the CSD programs in California, so we kind of help them develop their resources, materials, and hiring. I co-lead the lived experience integration team there, where we develop, review, present our own trainings, as well as support other CSC team development. My personal lived experience is with altered states, or what they call psychosis, and I've been doing peer support since about 2016. I started in peer respirant, so that gives a little context to why I'm in such a specific course bracket. Nice to see everybody.
My name is Kashani Saunders. I'm youth advocate for Berg Center for Children. And we actually have different programs. We have a FIT program, we have a juvenile justice system program, and both of them also have advocates. We serve Greater Sacramento, and we deal with a lot of families who have youth who are dealing with their mental health, whether that is trauma, anxiety, depression. I'm personally part of the FIT program, so we serve a lot of clients who unfortunately are struggling with their mental health. We also serve families who are struggling with housing. So if we happen to have a client and they're going through housing struggles, we also do our best with our housing benefits specialists to assist them with navigating how can they get housed, since unfortunately that is becoming just a huge problem within our community. A lot of the focus we do on our different treatments is DBT, which is a huge one. Another one we do focus on is, I just literally blanked out and forgot it right now. It'll probably come back to me. But when it comes to River Oak, we are in Greater Sacramento and also in Elk Grove. We have two different offices. I personally serve both the Elk Grove office and the Sacramento office.
Good morning.
Good morning.
Hi, I'm Shonda, Clinical Program Manager of Advocacy for Heartland Child and Family Services. And Heartland is a mental health agency that services children and families through Sacramento County. We have a number of mental health services that we provide through different core programs, FIT, FSP, we have a housing component, TDS, individual and family therapy, and our advocacy program, Family and Youth Advocates. Hello, I'm Letitia Peters. I'm the program manager of the Hope Cooperative Community Core Wellness Center in Sacramento. We have 3 core programs. Hope Cooperative is an agency that offers support to individuals who are unhoused, as well as have co-occurring disorders. We support with housing, we support with benefits, we support with CLTP, like co-occurring treatment programs. We basically, at my community wellness center, we offer a day center where individuals can come and just connect with peers, get light meals, get showers, laundry, a lot of connection, be able to kind of be in a non-judgmental environment, and yeah.
So the next question, Doug, you can ask anywhere you want. We'd like to hear from all of you. What are the key benefits of integrating peer support specialists into clinical behavioral teams, and how do these roles complement traditional clinical approaches?
I would say one of the key benefits is being able to provide a youth and family with somebody who has the lived experience who is then able to also kind of give insight to them of like, hey, I understand where you're coming from. Not only that, but there is hope to like overcome these challenges, and even maybe one day like you can also serve somebody like that in your community, and really just like instilling that hope. I know a lot of times when working with youth, they often feel like, oh, nobody really understands me, nobody really like, goes through what I go through, or like most importantly, a lot of times they will feel like, oh, I'm not going to be able to like overcome this. I'm not going to be able to be like successful in life. This is going to be something that's constantly going to bring me down. So I would definitely say something that just really benefits the families is being able to add somebody onto the team who that when they meet with them, it's not so much a clinical setting where they have to automatically like, go through, process everything, but more so somebody that they can just talk to about this is kind of the struggles I'm going through. And then in return, me as an advocate being able to share a little bit of my lived experience to just kind of really instill that hope of like, you can make it to the other side. You can get to a point to where this isn't really weighing you down, or you can get to a point to where people look at you and they won't even assume that you've been through so much in your past. And I would just say that's like one of the biggest benefits I feel like comes along with advocacy.
Thank you.
I agree with that. I believe that the connection piece, seeing the resilience of peers, and knowing that there's individuals that have walked that same walk as them before and are here to be here with you and walk that walk with you.
I believe the benefits for having peers would be peers bring the emotional intelligence to the clinical side, and so to the normal therapy approach. So they're able to bring that lived experience to build rapport. They're able to bridge the gap with the clinical language versus real life language that they can understand. And they're able to share their lived experience to connect with the families.
I agree with everything that's been said here. I think that's like one of the core parts of peer support. And, I also think that this is also about the providers that we work with, because we're coming in sometimes with a wildly different perspective. For example, I don't have faith or trust in the illness model. There's too much public health data, there's too much research for me to think, and sure that these systems are going to be healing for every single person. There's too much worldly knowledge that contradicts the idea that every single person is healing in these systems. So being able to have a dialogue like that in a clinical space has really even supported me this year. At least 2 or 3 providers I work with this year have approached situations differently than they would have before. Because I can go and do peer support anywhere. This is a lifestyle for me. It's the way I communicate with everybody. This is how I bring myself into every space that I'm in life. But in these program spaces, I get that very specific opportunity to interact with clinical providers who maybe have been trained in a very specific deficit-focused model. And so although I'm not there to try and convince anybody of anything, that's not my job, right? I think holding space to have a dialogue about what self-advocacy means, how maybe what the program itself is suggesting to a family might actually increase someone's sense of helplessness. That's a big issue throughout the system. It's important to allow people choice, so maybe medication isn't going to be what everyone wants to heal with. So having these conversations with providers who can then have conversations with families and individuals, so that's important to me and a key benefit, I think, of integrating peer support specialists.
Next question, what cultural or structural shifts are needed within a clinical setting to fully embrace peer support as a valued component of the care team?
I would say trying to find peer support specialists or trying to add on members of the team on the team from different cultural backgrounds who will be able to better connect with families that, for example, let's say you have a family and a lot of the struggles a client is struggling with stems from a certain cultural background. Not to say that, like, even if you don't come from that cultural background, you can't, relate to them and still connect with them. But it is really important to have people on the team who are able to connect with clients from a different aspect that I may not be able to, or even to have clients where they speak different languages, to be able to better communicate with families on a level that just some individuals may not be able to. I've definitely seen in this field where it just made a huge impact for families when either they were paired with somebody who just kind of understood a little bit more about their culture, or even when us as individuals took the time to kind of learn a little bit about the individual's culture, whether it's trying to understand how things were back in their home country and how that now has played impact on how they are out here, especially for families where, the parents are from the home country, but the child is being raised out here, and they're then having a lot of conflict with that. It's really helped out to just become more informed on the different cultures we serve and what are their norms.
I would say just changing from hierarchy to collaboration. And if we just work together with the clinical and advocate teams, clinical can work on the diagnosis while advocates are able to work on what's going on in the home. And then together we can support these families to be seen as people and helped and supported as people versus cases.
I would say, I was just gonna comment on the hierarchical structure, so just to expand on that, I think there are so many different ways of success, and there's so many views on basically how there are people above us in some way, and that we should kind of aim to get to this level. This is kind of an overarching societal issue, right? That valuing that is part of the issue here. So knowing that on a smaller scale, in order for our clinical settings to start to value other types of knowledge and peer supporters on teams, the teams are going to have to value experience and wisdom to the same degree they value that hierarchical structure, or they value an American educational degree. And to kind of get through that, there's going to have to be a lot of questions that people ask themselves on teams. There's going to have to be a lot of space to foster that conversation on teams, and really challenge the idea that one specific type of knowledge somehow translates to expertise on a human experience. One second big shift that would need to be is a level of focus on only westernized understandings of health and healthcare. Again, not everyone's going to heal in these systems. So blaming that on the individual, blaming the fact that, they're not, that this is a failure or whatever, blaming that on the individual with ideas like they don't engage, they're not compliant, they're not adhering to our treatment. Those would need to shift. I've rarely heard a clinician pose a question, is this approach right for them? Right? When faced with someone who's struggling, again, it becomes, they're not wanting to talk, or they're missing therapy appointments. And so the question becomes, what can we do to help them get back on track? As if the track you're setting for them is the exact perfect track for them. So maybe they're on the track they want to be on. Maybe their track is leading them away from a service that hasn't been helpful for them. That's how my journey ended up starting. So programs would need to shift this idea that's what's done in these healthcare services are what's healthy for every single person. That would open the space for peer support to be one of the alternatives that folks really utilize, and the value would be very apparent.
It really tries to make the idea that, well, we've always done it this way, or this is the way it's always been done. There are other ways to do it, and do bring that lived experience, which most clinicians don't have or aren't willing to share. They do have it. Next question: how can interdisciplinary teams foster mutual respect and understanding across roles to ensure peer voices are heard and valued in team decisions and discussion?
I would say, bringing them together, like, clinical staff and peers, like bringing the peers to the table. Open communication, having like meetings often where peers are there, hearing them out, listening to what they have to say as well, instead of just the clinical piece only, and they know it all.
Well, I'm curious with the panel here, how many of you, or how many of your peers are invited to the table with the clinical team? Are there, those MDT meetings, are they happening with everybody?
So at my site, we've developed a meeting once a month to where our outpatient part of the program and our peers come together, and we kind of discuss and collaborate different movements within the program, different clients, what's working well on our side, what's working well on their side, and different reports that we have, and it's proven to work. And we see that they're valuing more of what the peers have to offer and what they have to say in their relationships with the members that we serve.
I would definitely say getting to know your peers and getting to know a little bit about their lived experience. And then from the jump, when a client is starting services, or even if you had a client for a while, just letting them know that there are peer advocacy services, and then you also as an individual having understanding of like what it is we have to offer, so that you are able to kind of be like that first line of like introduction of like, hey, we have this support where this is kind of like their background and this is how they can possibly help you, just so that you're also giving our clients and families a choice of whether or not they even want to have a peer advocate. The reason why I'm saying like really get to know your advocate is because like how she's been saying a lot, not everything is going to fit for, every client. And it's really has made like a very big impact when I've had clinicians refer me personally to a client because they know a little bit about my background. Therefore, they feel like, okay, I might be a better fit for a client. Or we have one of our other advocates where, because of her background, she was like a better fit for another individual in a family. So really just for you guys to get to know us so that you guys can start seeing how we can really benefit the team as a whole. Making sure to just always keep in contact with us and case manage with us, even if our, let's say the goals I'm working on with a client or the goals you're working on with a client, let's say we're assuming they don't really align, you'll be surprised how they can overlap. There might be something that I've noticed like in sessions with a client that I can't help them with from, a clinical standpoint, but you guys can. So really staying in constant contact with us and case managing really has played a huge role. A lot of the clinicians I work with, there's times I feel like I talk to them more than my clients, but it's constantly keeping each other in the loop because there might be something that pops up for them that, talk to your advocate about that, So really just trying to stay together like as a team and just understand we all have the same goal. We're all trying to help the client, and that's the focus.
So at Heartland, we definitely, the advocates are a part of all those rooms. And we are in CFT meetings, treatment team meetings, and when following our CFT structure, it allows everyone to have an opportunity to share what's going on with their cases and what's going on from their perspective with the families. Also, leadership definitely includes us in meetings with just providing feedback or support to the families. So advocates are a part of Heartland's inclusion in those meetings. And that's important to have at all the agencies.
Thank you.
Just like everyone's been saying, having that dedicated space for a perspective to be able to be shared. We do it in our team meetings with the CSC model. We have team meetings basically for 6 hours every Monday. It's a lot, but in that space, there's dedicated time for family partners, for peer support specialists, for support education and employment advocate members to be able to provide perspective on something or offer feedback. Learning about each other on the team, just human to human, has been really helpful in the past for me. I worked in county, state, peer respite, all different types of areas, and team bonding has really been a core focus for a lot of those spots, and that's been really helpful to foster communication and also create a structure for when conflict arises, because sometimes there is going to be that conflict between folks with lived experience and clinicians, and so having that set in place can be really helpful as well. Thank you.
Next question. How can clinical supervisors and administrators support peer specialists in maintaining the integrity of their lived experience role while working in clinical environments?
So as a clinical program manager who started off as a family advocate, I definitely respect the confidentiality and build trust with my advocates, and also pace. So I, get to know them during the interviews, their lived experience and supervisions. We get to know each other, and that's all confidential with me. And so it's them that has the control of the pace of when their stories are being told, when and how much. And they are aware that it's a part of their position to share, but they're not forced at any time to just tell their stories when they're not ready. So we build that trust, and it stays with me. We hire them for their stories, so it's my job to protect those, and they have the control of when that comes about. Once you build that trust, they start sharing and oversharing. And so just building the trust is what.
Thank you.
I definitely would say building the trust, treating them equally, putting them in the rooms, in all rooms, advocating for them highly always, with same pay across. Yeah.
I would say a really straightforward answer here would be hire a peer supervisor who has extensive experience in peer support and knowledge of peer support history. That's not always possible, but very highly recommended. It's not going to be possible in a lot of spots right now. I think this is something we should be building toward. That's my personal perspective. I think for now, clinical supervisors and administrators otherwise maybe can have some more education in the depth of knowledge and the history of peer support, its purpose in alternative health, kind of how it got started, where it is today, variety of perspectives that peer supporters might have coming into these programs, and really it's going to be on the program leadership to ensure that the clinical supervisors and administrators are going to receive that training. I think, on the TTA, what we do for CSC models is for our peer trainings in our county consultations with them, we provide resources for further learning, like, for example, trainings through something like Wildflower Alliance or Cafe TA centers have webinars on there that are very simple to watch, and they're not running anymore, but they have great peer support resources, project-leds. We've contracted with Dr. Pat Deegan, who did an 8-series training for our counties on peer support in clinical spaces specifically, and how that differs from the peer support she describes as love freely given, which is the peer support I was trained in. So that continuous learning is important for supervisors and admin as well.
Honestly, a lot of what all these women said is really just getting to know your peers that you work with, and even if you do not supervise peers directly, still taking time to reach out to them, taking time to see, okay, how are things going with them and their clients, and if they ever need any additional support, as a manager. I know that for me personally, there have been times where I may not have direct contact with another clinical program manager. However, the clinician that works underneath them, we share a client And just from them being able to have a little insight of what my role is and what I bring to the table has helped out a lot, because they at times have been able to go back to the clinician and be like, oh, well, like, see if that's something Passion can help, like, the client with. So, and like that piece is really important, because, I'm not going to always be there to know exactly the needs of the client, nor is the clinician always going to be there. So just everybody being on the same page about what each individual brings to the table really is important. Another big thing is creating a space for peers to talk about, how they're feeling, to kind of talk about whether it's a concern, whether it's something positive, or whether it's just a thing of, hey, I feel like me and other members on the team are not on the same page. How can we get together to be on the same page? And having that be the focus of how can we all remember that we're all working together and we're not separate. That has really played just a huge role in things. The communication within being on teams, like within being on the teams. Sorry, I just completely messed that up. It has just really created improved communication with the teams that I've worked on, when we're all aware of what each person offers to the table.
Thank you. What strategies have proven effective in shifting organizational culture to value lived experience as a form of expertise in behavioral health care?
Can you repeat the question?
Sure. What strategies have proven effective in shifting organizational culture to value lived experience as a form of expertise in behavioral health care?
Something that I often will kind of compare my role to is, I feel like a lot of us know, what AA is, and the importance of having a sponsor, to have that person that is just right alongside that person as they're going along their healing journey. I would say another thing to do is, even if you as an individual, you're questioning whether, what's like the benefit of somebody with like the lived experience, just ask yourself, like, when was the last time you talked to somebody who just really felt like, okay, they get exactly what I've been through, and just think about how that made you feel. To sit down with somebody and have them kind of share a little bit of their lived experience and kind of like instill that hope into you of like, oh, okay, you get exactly where I'm coming from. And not just only have it be when you're in therapy, with somebody, or think about your connections you have with your family members that you're really close with, or like your like best friends, where you guys probably have a lot of shared lived experiences, and how that has played a role into you guys just really fostering your relationship. So I would just encourage you guys to do a lot of self-reflecting yourself. That sounded weird. But just a lot of self-reflecting, to just really think about your own lived experience and the type of support or the type of individuals you would have wanted around you to instill that hope.
I would just say inclusion, just making sure that advocates are included in those meetings, in those discussions, in those conversations, and just allowing them to be using the inclusive language in the agency.
Thank you.
I would say more opportunities for growth for peers in higher positions, seeing them for all of their strengths and what they offer, more communication.
Thank you.
I guess I'm gonna play devil's advocate a little bit here. On a wide scale, I'd say there's not been a lot of strategies that have been effective. On an individual level, like between me and another provider or a few other providers, what's been effective has been the back and forth learning. So I learn from them what their perspective is, where they come from, who they are as a human. They do the same for me. And this is again, like I said, for support's not a role for me. This is just how I interact with people at this point in my life. That reciprocity is always going to be there in the partnerships that I have. So it's not about being right or telling what others are good for them or what's better for them. So there are providers who really value that because of the way I approach the relationship with them. And they start emulating that with the other providers in their program. There have been providers where I've been in situations with who hold very deeply onto their titles and their way of knowing, and that's okay too. I'm not here to tell them that that's wrong. I think focusing so heavily on shifting entire organizational or structural cultures on teams right now in these clinical spaces, that's how I came into these programs a while back, and it wasn't working. So what started working was getting back to the basics on an individual, on a small group level, getting back to human connection, and really creating that space in that program. That's what's been helpful.
Thank you very much. And lastly, how can behavioral health organizations ensure that peer support roles are not only included, but also adequately resourced, trained, and valued as part of a multidisciplinary team?
I would say that this, at Heartland comes from the executive leadership and bringing that from the top down, just having that culture and they honor and they respect advocacy and the lived experience, so it spreads through the agency. Does it stay? Is it perfect? No, because people come in and out, and so it's something you have to keep doing and keep introducing. But as long as the top believe in it, then everybody will follow through and they'll understand the vibe, of the agency.
Sure.
Yeah, honestly, a lot of what she said, just having it to where it's just a known thing at the agency that we have advocates and that they play a huge role, and that it's not just, I would really say, really making it known that advocates, it doesn't just have to be, it's something that's just optional. It's something that is just well known, it's constantly talked about in all spaces from all different levels, and it's just really seen as this is what we offer at this agency. This is what we have at this agency. This is part of our agency. Because I know for my agency, not trying to brag, but I feel like we're known for having advocates. We're known for having youth advocates and family advocates, and we are known for the impact that the advocates have on our clients. And I think what's played a huge role in that is just having our agency as a whole really respect our role and really include it into all services.
I guess I got a question to this question that it doesn't need answering, but I guess my question to this is do these roles have to be included on these teams? Because from my perspective and from just my history in peer support, to require peer support roles in clinical programs, from my understanding, is like requiring someone to heal in a very specific way. It also opens the floodgates, right? Like we've seen already, organizations being pressured to hire staff. There's not a lot of structure, no one's prepared, peers are being hired as peer case managers, roles are getting confused. Over the last 2 years that I've been up here, there's been peers that I've talked to who said they're in this role and they have no idea what to be doing or what they should be doing. So kind of, are we emulating the systems disorganization and hierarchy and pressure to move fast? Because it's never really seemed one of the goals of the peer support community to me. I'm open to being wrong about that, or maybe goals have changed, maybe things are shifting. But I think if we as a California community can kind of come together, provide greater structure to this, depth of perspective in our trainings, model the communication styles we hope will be on these multidisciplinary teams, then we can start talking about what behavioral health organizations might want to do if a peer support role is going to be a good fit for them. There should be a process for this, such as learning the protest history of peer support, the value of the system of peer support, the type of compassionate connection that's strengthened through peer support, and all the intersections of all other types of movements that peer support is intersected with. Then we can start talking about whether they feel they want to welcome perspectives that may challenge Western understanding, clinical understanding, biomedical understanding. And if they feel there's enough time and funding to put effort into learning and all of that, then we can start talking about, okay, let's get a peer support role set up in this program. And that's coming from my very specific perspective, but it's just based on my observations in this community.
Thank you. see, is there anything any of you would like to share individually? If not, we have some time, we can open the floor to questions if you'd like that. Is there anything? Yeah? Okay, so at this time, if you have a question you'd like to ask one of our panelists, raise your hand. I have a runner in the back with a microphone. We'll bring it out to you. And we can see if there are any questions for any of the panelists today. Up in the front. Small.
This question is not to
all of you Yeah, hold on just a moment. We're getting a mic on you so everybody can hear your question, okay? Can't be shy now. There we go.
I have to look it up.
A little bit. Pretty close.
Okay, so that's what I get. So my question is, so you guys feel like we need to bridge the gap, even if it wasn't just special, like bridging the gap between different agencies in the county or state agencies when it's coming to help like our youth, our kids, like everybody, like I know that you guys, I love all you guys, hours, but there's other people that kind of put a stigma into it, or they might not really care about what's going on. So how do you guys bridge the gap between agencies that are not supporting people like we're supposed to? Like that could come from how you guys are helping with mental health, or you're advocating for youth. Even though we have that system, I work with many, lots of different things. So me trying to be a peer support specialist now. Because sorry about that, how do you guys implement that and make sure that you guys are, helping everybody out to where you're really, truly want to help them. There's some people that don't. So I don't know if I can ask it correctly, but how are you guys going to bridge the gap when some people that are in agencies don't help? So how are you guys going to make sure that, everybody, needs together as a team, connects with people? Whether it's homelessness, mental health, all that. Because there's a lot of people that they say they're going to help, they never do. So if you're going through that situation, whether it's a youth, an adult, single parent, just anything, how are you guys going to connect with other people that say they're there to help, but they don't necessarily help?
I think basically for us to keep showing up ourselves, keep showing up, keep doing what we do, keep advertising, keep networking, keep going out in the community and advocating for the space, what we do for our people, just different community events, consistently. It's going to be a consistent battle. I think it's always going to be a consistent battle. So I think just continuously showing up and really speaking our truth and advocating.
I would definitely say when you're working with families, really role model to them, one, their rights, and also two, what services are available to them. And I don't know, this might be a little controversial, but role modeling to them how they should be treated by these agencies. Because their voice is really important. And it's one thing for me to go to another agency and tell them, I don't think, hey, I think you guys should do this differently. But it's another thing for the client themselves, if they have to go to another agency, for them to know, hey, I know my rights, I know the type of support I'm looking for, and really just instilling in them, you have every right to advocate for yourself, no matter where you're at. Whether it's maybe I just want a different person on my team, or hey, these are the type of supports I'm needing and I'm waiting this long. Really, really working with your families and teaching them how to advocate for themselves. That's the biggest thing.
So can I ask that? So when I mean different agencies, so that's, you guys, all of us come together. So when it comes to the justice system, whether it's juvenile system, that's where they need to do multicultural, or we need to make sure that they're there. So that's when it comes to that situation, they might say they're there for the kids, or they're there for the adult, but mental health, of course, all that, sometimes they are there, so that's the part that we need to do.
I think majority of the questions trying to say is, how do you network? How do you use other networks to make your system work better? That's basically what I'm getting from that. So if you're able to utilize other networks, that will help you in your job placement to access more for the client.
So I'm hearing a lot there, and I think from my experience doing that type of networking, I think one thing that's been super important is the acceptance that not every gap is going to be bridged, and we can't pressure that kind of like, okay, we need these services for these people because they need it. I think part of that is listening to what services people are asking for, what they really, really feel like they need, and finding ways to kind of go into those spaces and see who might bite and who might not. And I think so for every gap that's not bridged, there's gonna be another gap that is bridged. So I think just kind of keeping that in mind has been really helpful for me in networking with different agencies, especially more challenging connections.
Thank you. I think we have another question back.
Hi, everyone. I'm Katie Sommerfeld. I specifically would like to hear anybody's perspective on what you think positions for peer support specialists in systems like CareCourt and other models that are more clinical, have a forced treatment element. What do you think peers could do, one, if they don't really know the fidelity of the peer model, especially from a grassroots level, also adhere to, if they're certified, adhere to all of the principles and the ethics that we signed and promised that we're gonna uphold, but still be in a system that doesn't know, doesn't honor, and doesn't make space for people to really do that. What do you think would be the best way for people to work in those types of jobs in Sacramento County?
Hi, sorry, right before you answer, I just want to make something clear when it comes to CareCourt. It is a voluntary service, so no one is made to get treatment. They can say no at any time, just like they get in any other treatments that are provided.
That's why I'd like to hear the mixed perspectives, because there's always going to be that division.
Well, we are.
No, I never said everyone. I never said everyone.
Yeah.
Someone on the panel want to share?
If possible, could you repeat the question? And I kind of got a little lost.
So there's clearly a division amongst peers who come from, more of a traditional grassroots understanding of the peer model and had a lot of opposition against CareCourt. And then there's peers that are going to be working in that system that don't even understand what true peer advocates should be doing in that system. And I'd like to know what you guys think about what that could look like.
I'm negative.
Okay.
Yeah,
I go.
I'm hearing a lot there, Katie, also, because I'm not sure I'm not sure why CareCourt is being brought into it specifically, because I think understanding what peer role is from a grassroots perspective or understanding should be applied in any situation, in any environment we're working in. I've been through CareCourt, it worked for me, but that's just my perspective, my experience, so I'm not sure why we're going that route, because I think it could be anywhere, really. I mean, understanding where peer support came from and the grassroots of it is fundamental to our working as peer support specialists, in my perspective. So Somebody else want to share on that?
Yeah, I think that the overarching theme here is talking about potentially coercive treatments or treatments that are feeling coercive to certain members in the community, or are being put in legislative language that is not really accessible to everyone here. Like, I know the legislation that I read on CARE Court, I was working for the state when this was coming out, I was working for the state when Prop 1 was getting ready to be done. There's a lot of drama there. I would love to get into with anybody on a personal level because of how things went with that. And so I think that something too important to remember is, again, not everyone is going to heal in these systems in the way that maybe you have healed in these systems. I did not heal in this system. I got out of the system. I do not do any clinical anything. I do not personally take medication. That is my personal choice. There are certain things that just don't work for everybody. And I think, so kind of taking it to that more broader perspective. I think when you're working in these systems, at least for me, like in the early psychosis, however you would like to say it, in the early psychosis realm, CARE Court was a really big conversation. We only want to work with folks who are hearing voices, seeing visions, etc., and having unusual beliefs. It was not something that our NPCal TTA was super behind. It's just not. And I think that again comes from the breadth of experience that has been brought to our table. Some folks find it very useful, other folks find it not useful. So I think being able to hold that duality is something that's going to be important if you're going to be a peer supporter working in these spaces. This is not going to be perfect for everyone. So holding that is going to be extremely important to get to your question, Katie, is holding that duality, holding these multiple truths.
Thank you. I've been made aware of the time here. It sounds like we could have a lot longer discussion here. Maybe we can take that into consideration for next year with our panelists. If you're requesting more time for open questions. I do want to thank our panelists here today, Alicia, Leticia, Shonda, and Pashini. Thank you all for being here. We are going to have time for a break now. We will also have time during lunch. If you have more questions, maybe you can catch up with them individually and continue the conversation. Thank you.
Real quickly, before it gets too loud, clap if you can hear me, clap one time if you can hear me, clap twice if you can hear me. Awesome. Just a couple of quick items before we keep rolling. Just remember there are a lot of outside activities we want to invite you to engage in. There is the QR codes around the room if you want to share photos. The conversation that we kind of just ended with, if you are not already, I really want to encourage you to attend the peer committees that are happening within the county. I know Roxanna's in the back and I'm calling her out right now. But the peer committees can be a very good place to have some of these conversations. Like if we're working in these more clinical programs, how do we maintain our appearance and have those conversations with each other? So I think that's a really good opportunity to continue that conversation. So I want to welcome you to do that. Connect with each other. But I also want to I have a couple reminders. Please silence your cell phones during sessions. I heard that a few have gone off. Also, we want to invite you to visit the resource tables during the breaks and the lunch period. We have quite a few vendors in the back. And I think that's all I got. So you don't have to listen to me anymore. We will start back at 10:45.
I was late and I was out of space while being down here with some of my and I forgot Ricky is also with me.
Hey, welcome.
I know, I love it. It's so slow. I know, I want to go and get the ball. I love you so much. I know, I have my favorite. I know.
At first, I was like, I can go to LA and then Sacramento, but it's like 6 hours. You got a long drive, but it's a good flight. That's right. Water there, I might you should have. I'll ask.
You want to know? Oh, yeah, okay.
Okay. All right. So I do have to say, the slide deck is it's like history. I have a Canva document from your thing. I'll do Oh, is it?
Can you airdrop it?
Let me, I'm not sure.
Okay.
Yeah.
So they'll make the next time is great.
Oh, that's great. Yeah, just be like, no, stop. Stop talking. You know, once, because like I've done a lot of like different speaking engagements, so when I've offered like introductions, they just put off. Or like other you have to hear me. It is. Trying to do that. It's.
Ebony, you can give us. We met before.
On Zoom.
Okay, on Zoom. How you doing? Good to see you in person. I know. Ebony's one of my favorite.
It's awesome. Yeah.
I was checking out for you because I was like, how's the setup work quickly? You want me to send it to you instead of connecting it? Okay, yeah, no, that's fine. I can do whatever you like to do. I have a regular. I mean, I didn't bring my, I have a Mac, I didn't bring it because usually the compatibility is up, so I have to bring all the extra attachments up.
Yeah, I'm just kidding. And then we just
I actually thought about this. I was like, I wonder if we'll make it. Yeah. Yes. Yeah, that's right. I just realized I just assumed that, yeah. And then I know myself. I know.
But just to, if there's like, you guys think I can bring, not to be on camera, but if you invite staff, like, I know I could. And you've been here for so long. Yes.
will say, just getting to know Los Angeles and Sacramento, there has to be so much community. Like that's a lot
Yeah. Yeah, well, it's interesting. That's what my last keynote was in LA, Anaheim, a few weeks ago. I mean, but it wasn't with peers. It was with the Association of Superintendents for the state of California, and it was around like LGBTQ and all of the changing laws and things like that. So it's a completely different crowd. We'll try.
You gotta love
I kind of had to be like, if you like something, snap. If you hear something, like if you hear an A, appreciate it. All right, so I'm gonna let you go. Thank you.
It's been better than I thought it would be. Just be so close to it again.
Doesn't work case scenario.
It's always a very understanding very tiny words, just a big crowd. I can tell you all about it, and that you don't know.
Looks like it's on.
It should be even trying to be in the state. They're probably together. But specifically, this is where you kind of like, I kind of put it out there. I think a good strong contract. Okay, I'm not even a training personnel grant. I assume it's like $1 billion. That's really good longevity and stability. And like me, I'm really passionate about training.
And
You don't even have to be one of the tiny entities in the peer personnel. I think that's awesome. And I think that it's even partner with one of the training entities, and after they go through that, they can go for extra placement. And so if you're saying every day training after that, you're every single guy. And a lot of our peer providers have something to think about. And it's like, okay, you can do something for pay for time. And so I feel like they're going to be great. So what about so your bill was fine. And then people like, oh my gosh, yeah, no, so I think I'm worried
you're shutting down.
like I did it. My God, he was never
It's like humility trying everything. It's not even like that. So it's interesting. See this great South recap.
I think a lot of people here don't so deep into this. They're like, I've been
Yeah, I'm gonna fix it right now.
So I'm working with PRC, and I introduced the recovery.
Sorry.
This is what we do on the state level. And we'll talk about that in training stuff. But I mean, what Jason was telling me was Peer Run Drop-In Centers being recategorized as clubhouses. That's going to decimate the law. It's going to decimate. So
It's totally different. And also, like, they're like, oh, Clubhouse International is the TA. And I'm like, well, that's it.
yeah. So maybe it's like it has to fail, and then they have to be like, oh my god.
We have 11 wellness centers here. And I'm like, they're all going to get like, oh, why don't you? So it's hard. But we're getting all
It's good to be in California. I hope you had a good time downtown yesterday. Where'd you go? I did. I just went to a coffee shop. It was like this like One World Coffee or something, or World Traveler Coffee. They had like a huge mural of just Pangea, and I'm like, I don't know why they're like one humanity, and I'm like, oh my god, all right, great. So I'm like, that's a lot for coffee.
Yeah.
That's good.
It's a good cafe. I'm not going to pronounce this right. It starts with an S. Yeah, they do really good downtown. They got like all the coffee, all the different fruits. That's all the spots. Any kind of coffee drink.
This will be fun. It's going to be a lot of movement history, and then I'm going to try to bring in different breads. Yeah.
Like this has I could have missed part of it, like how to do the monkey. Oh, yeah. But she's been alone for like 2 hours already. It's the longest time.
Thank you for being here.
Did a kick-ass
I
job.
was like, I need someone on there that's like, yeah. That's the niceness. I mean, you were nice, but like, and let's be real. Like, which I would, and I thought that would be a very good transition.
Yeah. All right, let's go.
You
You want this mic here?
Hello. We are going to start welcoming everybody back. We're going to ask that folks can find their seats. If you have not yet, we still have some water and coffee available. So if you can hear me, clap once. If you can hear me, clap twice. If you can hear me, clap 3 times. I'm working on it. I don't know what happened. Ooh, the button works. Excellent. All right, we're going to see if folks can find their seats. Do I have a staff available that can let folks know on the patio that they can come back inside? Katrina, yes, would you let people know on the patio that we're going to get started? Thank you. Thank you, everyone. everybody. Please go ahead and find your seat. All right, folks, if we can find our seats, can we wrap up any conversations?
Eggs and bacon.
All right, if we can find our seats, we're gonna do one more round of clapping, and if you can hear me clap once, if you can hear me clap twice, if you can hear me clap 3 times. Beautiful, beautiful, thank you. We are very delighted and excited to introduce our first main speaker for today. You may have seen Vesper on, could have seen Vesper on the news, on webinars, on television, on all kinds of places, because Vesper is a nationwide expert on peer support. So I'm going to read a nice bio to introduce Vesper, and then we are going to hand it over. So Vesper Moore serves as the Chief Operating Officer at Kiva Centers in Massachusetts. As an Indigenous activist and leader, Vesper is deeply committed to promoting mental health and disability rights through activism, leadership, organizing, public speaking, and education. Their work focuses on cultivating social movements and raising public awareness to foster lasting social change. Vesper has contributed to the establishment of mental health organizations worldwide and has been an advocate for civil rights in the United States. Through their advocacy, they have brought the perspective of people with mental health challenges and disabilities to both national and international platforms. Collaborating with the United States government and the United Nations, Vesper helps shape strategies around trauma, intersectionality, and disability rights. They've been featured on NBC News, PBS NewsHour, Politico, and the White House. Vesper is at the forefront of legislative reform, striving to shift the societal paradigm surrounding mental health. So if we can all welcome Vesper.
Thank you all for that great introduction. And I really appreciate being a part of being in this community space, even if it's for a little bit of time. And I've been saying to a few people, I'm just like, one community in California, there are several communities, just geographically large. There's so much going on. A lot of my work started in Massachusetts. I think something that isn't necessarily in the bio immediately is I'm someone who was hospitalized for 4 years as a teenager, and I'm someone who had a parent who struggled with suicide and attempted suicide. I myself attempted suicide. And I grew up in a very difficult neighborhood with a lot of gun violence. So I think there often when we share sometimes these stories or we're talking about the work that someone does, we start from this place of, oh, look at all these achievements. And in truth, there's so much that I endured to be here, and that many of you have endured to be here. I want to start there. And I want to say that when we talk about the history of our movement, which I'm going to be talking about a lot, at least in the context of mental health peer support, because there's so many different recovery movements and rights movements that are important to what we know today. A lot of it started here in California. A lot of it started in San Francisco. A lot of it started with people coming out of institutions and not having enough services in the community. And a lot of it started with police violence and many other things. So I want to name that, and the movement was led by, and is led by, people who are ex-patients, survivors, peers, consumers, people who had direct life experience, who have direct life experience. Because leadership of those most impacted goes a long way. If you are talking about social and health outcomes,
If you actually do care about public health outcomes, if you care about healthcare, if you care about a lot of these things, you do in fact need, I think a lot of people like to say, oh, you need qualitative data and quantitative data. What's behind that data? Lives of human beings, the experiences that are shared, and the things that we do. So this is maintaining the integrity of peer support, civil rights, and behavioral health. And the reason why I like to start from a perspective of civil rights is there are several civil rights that we have fought for. The first that I want to start with is Olmstead, which is the right to live in community desegregated from institutions. People were warehoused in institutions in the 1960s, all the way until the 1970s, and arguably they are today. So I think when we talk about everything from system reform to changing things to system transformation to a lot of these ideas that we're trying to explore here, you need leadership of those most impacted every step of the way. You will have a lot of times where you organize together and you agree, and then sometimes that will diverge and you will disagree. And I want to name that that's okay. Every social movement, every social struggle, every community has that. But finding opportunities where you can work together. So for example, I am someone who was committed into a hospital. I had a very terrible experience being committed. And for me, it was thoughts and feelings of suicide, a suicide attempt, ending up in the hospital. And then in that space, I felt more isolation. I didn't have as much connection to community, which didn't really treat or address the root of the issue that I was going through. Whereas I've known other people who they're like, if I wasn't committed, I wouldn't be sober right now. So I want to honor those two difficult truths as we go into this space and as we talk about this history, because they are difficult truths. I like to start with this quote here, which is, if there is no struggle, there is no progress. Those who profess to favor freedom and yet depreciate agitation want crops without plowing up the ground. They want rain without thunder and lightning. Power concedes nothing without demand. It never did and it never will. And it is the truth. I think when we talk about the very existence of peer support today, the fact that all of you are in this room, that you're either supervising these roles, working in these roles, working on contracts associated to these roles, doing any of these things, you wouldn't have any of this without a civil rights movement. I'm going to be very honest with you. If there was not a fight for civil rights during the age of deinstitutionalization in the 1970s, you wouldn't have any of this. You wouldn't have your jobs, you wouldn't have these community spaces, you wouldn't have many of these things. And there's such a distinct value in how we need to fight for the funding to sustain these things, how we need to maintain the quality of what these things are, the integrity of what these things are, and the value system. I know that grassroots peer support and organizing efforts and a lot of these things might be very contrary to the systems you know today, such as like if you're trying to navigate a Medi-Cal system, if you're trying to navigate all of these different things. And that's because a lot of those things were developed at the very height of a lot of these institutions. So, and were developed by design to keep the beds full, because you bill per bed, to make sure that you could have all these, and maintain funding for these spaces and prove that, oh, okay, it is per body, per person, right? Whereas the peer support approach, we're not really concerned about the exact amount of people we're reaching, though reaching as many people as we can is important. But what's most important first is actually the quality of the support that we offer each person. The way that we show up for people each day. So I think as we get into this history, I'm going to talk about institutions. I'm going to talk about where we've been, and then I'm hoping that this will help us, really think about where we're going.
All right, so I have a timeline here, a little bit on the 1700s, 1800s, 1900s, 2000s. I probably won't cover all of this. It's about 375 years of history, but I'm just going to graze over a lot. Content warning, there might be a lot in terms of like human rights violations, things you might hear. I'm sure many of you work in situations where there may be at times human rights violations at agencies. When you think about the roles of human rights officers, which are designated by state agencies as designated by the federal government, the whole reason why human rights officers exist as well is because of the abuses perpetuated in these institutions. So when you think about the role of peer supporters today, I like to think of it's both that fight for human rights and maintaining that fight for human rights and trying to change systems to take a better look at, are we seeing the whole person? And then you have the other aspect, which is also being in community, offering that compassion, being in the space wherever someone may be, and trying to not think about all of the barriers that can be in place, such as, again, billing, referrals, all of that, but how can you reach people? How can people access behavioral health care on their own terms as much as possible? That is the question that civil rights begs. That is the questions that the Americans with Disabilities Act begs. That is the question that Olmstead begs. A lot of these civil rights that we have today. And the reason why is that when people didn't have access to supports in the community, they ended up in institutions. And then there was this idea of, oh, well, when you're in an institution, you don't really recover because you can't recover because you experience this illness and you'll never lead this quality of life. Then we moved into rehabilitation, which we still see in institutions such as correctional facilities today. And that idea of psychiatric rehabilitation was basically like, oh, well, you could rehabilitate with a lot of time of work, maybe 10 to 20 years of work in an institution, and maybe you can come back out. You'll never be a functioning member of society, but we can rehabilitate you. And then it moved into movements for recovery and ideas of recovery. During this time, I'm going to be talking about the consumer survivor, ex-patient, ex-inmate movement. Globally, there's this complex history of harm and a lot of different movements that have fought against things like forced treatment conditions and really opted for how do we uplift voice and choice and autonomy as much as possible. I understand that it can be challenging. You might be working with a wide variety of folks who have been involuntarily committed, or you might be like, what options did they have in the first place, right? Or maybe you feel like you don't have enough time and the amount of people you're working with are just so many. I want you to think, if you were in that situation, if a family member of yours was in that situation, would they want the professional, the person with lived experience or otherwise, who's working with them, would you want them to try every possible option beforehand? Like exhaust every resource, go to every space, try every solution with patience, compassion, and kindness. Do you feel that? Okay. So I think when we talk about the issue of involuntary commitment, and it's in most of the country, the concern really comes back to, are we trending towards where we have been before with institutions, where we had to lead to a movement where we had to try to close a lot of these institutions and then build services in the community. I mean, think about it. You have billions of dollars in community behavioral health centers across the country. You have many different attempts to build all of these integrated teams, to do all of this work. So much investment in community initiatives. Why would we backslide? It's just an important consideration. I think part of the reason why we may tend to backslide is there is
There is a desire to, again, and a drive to keep beds full. That is the system, that it is designed to keep beds full. And that has nothing to do with our feelings. I just want to be very clear, that has nothing at all to do with our feelings. That is about the fact that this system is designed to bill per individual and keep these beds full. So when you operate off of the very thought process of a lot of these things, it's so important. But looking back at the first institutions in the world, one of the first recorded institutions was in 792 AD in Cairo, Egypt. And then in the 1400s, you had the establishment of madhouses, post-Christian Reconquista. So we're talking about this idea where like a lot of people who were being institutionalized were thought to either have troubled souls or were needed to be kept away in some way. So when we see parallels in modern day history, there's the question too, when we talk about people who are living on the streets, people who might be in need of resources, and how many of them are then taken off of the streets because of the concern of property value, because of the concern of public acceptability, because of a wide variety of concerns. And I know that these issues are so much more complex and there's so much in between that, right? Like maybe someone is, in fact, actually posing a danger to themselves or others, right? Maybe there are these circumstances that arise, but also how much of it is also the presumption of danger? How much of it is the assumption? And how many times are we not exhausting every resource and option supporting that person? And we find it easier to simply streamline them, put them into some type of service immediately, whether or not they want that service, whether or not they voluntarily accepted that service. So when you think about this history of madhouses and places like Bethlehem Hospital, I mean, if you ever heard someone say, oh my goodness, it's chaos, it's bedlam, people are talking about that word bedlam comes from the name of this psychiatric institution, Bethlehem, in 1547 in London. So the very idea of containing and keeping people away was something that we've always seen historically. There was a petition of the poor and distracted people in the House of Bedlam in the 1620s. And I'm going to tell you that legislation targeting specifically people either who are living on the streets or who are houseless has existed for a very long time. Up until the 1970s, there were these things called unsightly beggar ordinances or ugly laws, which meant if you were someone with physical disability, if you were someone who was unsightly to the public, you had to be taken out of the public view. So you had to be contained, you had to be put somewhere. That existed till the 1970s. That's not that long ago. So I want to emphasize that. I think sometimes people might not see certain things in their lifetime, and there's a disconnect. And I really want to state the reality of this, that when we think about the future of behavioral health care, when we think about the future of what we're doing as peer supporters, as professionals, is it still rooted in the very idea of human rights for all people? So in the 1700s, in Virginia, one of the first asylums opened, and it actually opened 3 years before the Declaration of Independence was signed. So we've had asylums longer in the United States than we've had the establishment of the United States. At the end of the 1790s in France, there was something called the
this idea of the Enlightenment era, where Felipe Pinel and Jean-Baptiste Poussin, they tested the hypothesis that patients would improve if they were treated with kindness and consideration. Pinel's patients were unchained, they were provided sunny rooms, given nice clothing, and allowed to exercise on asylum grounds. So keeping in mind that up until this point, at least according to the historical record, there hadn't been a time where patients were unchained, had access to clean clothing, or regular sunlight. And this was a revolutionary idea at the time. In the 1800s, from 1840 to 1880, the United States Census included categories such as insane or idiotic, which was widely used to support funding and policy decisions regarding the creation of large asylum buildings and psychiatric incarceration. The census of 1890 dropped those terms, replacing them with defective of mind. At this time, prisons, jails, workhouses, asylums were utilized specifically for the sick, elderly, mentally ill, in quotes, children, and learning disabled, and the conditions were horrific. So why is this important? When at the very root of the services you're building, if there are a lot of human rights violations that go unaddressed, and then you continue to build policies and procedures off the foundations of a model that may have harmed a lot of people and has gone unaddressed, what will it do? It will harm more people by design. So this is why this history is important. You might be like, but Vesper, people aren't being chained right now. They have access to the sunlight. They have access to a lot of these things, right? But I can tell you that people like myself, Black and brown people, like we are like diagnosed disproportionately with psychotic disorders. We are diagnosed with or labeled with things like oppositional defiance disorder. We are disproportionately on forensic units and in prisons and jails. Everyone should care about that. So now we're going to get into a little bit of like asylum reform movement history. There was a group called the Alleged Lunatic Friends Society, which was a group of ex-patients or ex-inmates who are coming out of asylums and they wanted to reform asylums and change asylums. So this is the first instance you have like people with lived experience, right? Who are coming in, making policy decisions, choices. This is in Europe. And actually, I forgot to mention, when we were talking about Felipe Pinel and Jean-Baptiste Poussin, they found that hiring former inmates to work as employees at the asylum led to better rates of people feeling better. So I want to say this is another early instance of peer support in institutions, or peer support in a way. Dorothea Dix was an American treated private Quaker hospital, and she was in England during this time of her treatment, and she was a psychiatric nurse. When she returned to the United States, she campaigned for the establishment of state hospitals and moral treatment, traveling across the United States. So the reason why Dorothea Dix is actually important to like my story, for example, is I was hospitalized in the Worcester State Hospital. I spent a year in that state hospital. And Dorothea Dix, her early reform was at the Worcester Lunatic Asylum. She was fighting for reform, which was an asylum that still exists on the same grounds as that institution today. So when I think about like 300 years ago, when Dorothea Dix is fighting for asylum reform, and then me today, I'm fighting for institutional reform and change, that it's like, oh wow, she was here on this same ground, on this same soil,
fighting for policy reform at this time. Wild, absolutely wild, important history. So I think when I think about that history, it gives me chills. I think another thing, aside from my work at Kiva, I also serve as a commissioner on the Special Commission on State Institutions in Massachusetts. So that's a state appointment. I served in that position for 3 years. I had to put my hand on a Bible and everything, and do an oath of office. So it's one of those positions, and that position is specifically for a person with lived experience in mental health recovery. That's what that position is for. And the other piece is that I work with researchers, I work with archaeologists, I work with archivists to study unmarked graves at state hospitals and asylums. Because when you would die at one of these institutions, you were given a number. You didn't even get a name. So for me, the work right now is, are we remembering these people? What were their names? Who are their family members? Do they have any living relatives? All of that work. It's deeply painful. Some of the people who serve on the commission were institutionalized in some of these institutions that just closed, that they were abused in. Some of them are former hospital staff. Some of them are family members. We all disagree. We all agree on many things. We disagree on other things. But one thing we can agree on is those institutions closed for a reason. And if we want to move forward in Massachusetts towards a better voluntary community-based behavioral health system or community, then we have to continue to realize that we have to do this together as much as possible. So this is Clifford Beers. Clifford Beers founded the Mental Health Association. Unfortunately, Clifford Beers, a lot of the movement ideas ended up being grounded in eugenics a little bit because of the very fact that he was talking about by having good mental hygiene, by maintaining this hygiene, it makes you more normal or better in these ways. But I will say this is one of the earliest, I mean, we're talking early 1900s. This is one of the earliest attempts at really starting to talk about ideas of mental hygiene. We don't have to be institutionalized forever. We can try to improve. We can be contributing members of society, right? So we didn't get into any of that critical dialogue yet. But anyway, he wrote a book called The Mind That Found Itself. The Mental Health Association became Mental Health America. It's been around over 100 years because of this guy. So when we talk about eugenics, sterilization of Black and brown women was common practice in places like Indiana, Virginia, and ultimately upheld by the United States Supreme Court, mandating forced sterilization of patients of state mental institutions, psychiatric facilities, and developmental disabilities. This policy was in effect from 1907 to 1979. So again, when we talk about recent history, forced sterilization is also recent history. And then here we're talking about lobotomy in Portugal. So when we talk about the first lobotomy, it was performed in Portugal in 1935. You have electroconvulsive therapy, which used to be known as electroshock. That was introduced in Italy and gained popularity in the 1940s and 1950s. In the 1900s, there was insulin-induced shock, very, very painful. And again, this is why I offered a content warning earlier. There's some imagery and mention. Insulin-induced comas, also known as insulin shock, were widely accepted from 1927 to the 1950s until it was scientifically proven that insulin was not a therapeutic agent. And then now we have a huge shift, right? So in the 1940s, former patients in New York created a self-help group called We Are Not Alone to help each other and other ex-patients find jobs, housing, and friendship, probably the most important part, friendship, by meeting on the steps of the New York Public Library This held to the creation of Fountain House in 1947, which was the first clubhouse in the world. So the clubhouses really come from the psychiatric rehabilitation movement. So the idea of work ordered days, the idea of learning to work and do a lot of these things, it comes from this idea of psychiatric rehabilitation, which is the first iteration of a lot of these things. Peer support in the context of mental health comes from the consumer, survivor, ex-patient, ex-inmate movement. You had a lot of people who came from the psychiatric rehabilitation movement and clubhouse movement who are a part of the modern day peer support movement, but these are two different historical lineages. And the reason why is that the clubhouse and the peer-run drop-in center and access center operate two different functions today. There isn't necessarily the requirement of it being peer-run, and in peer-run drop-in centers and access center spaces, it's not necessarily that idea of like a work order day or sometimes a state referral or some of those pieces. That's not to say that you can't have peer supporters working in both environments and that both environments aren't valuable. They're just different. So I think sometimes there's conflation that can occur with programs, but they have separate histories. They have separate benefits. When we talk about peer-run drop-in centers and access centers, the reason why they're so important is a person can walk off the street, whether or not they have behavioral health or mental health diagnosis, and receive support from someone with direct life experience. Invaluable, absolutely invaluable. Without a specific trajectory or treatment methodology or thing like that, simply to engage and be in a new environment that is led by and created by those who are most impacted. And clubhouses, when we talk about this history, you have ex-patients who started this group called We Are Not Alone. And the whole idea of We Are Not Alone was to be like, hey, like we're coming together, we're coming out of these institutions. How many people are coming out of institutions who don't have community, friendship, support, or the means to obtain employment, to obtain opportunity? That's why the clubhouse model was developed. But at the very center of that is community and lived experience. It started with those two things. So National Institute of Mental Health. The National Institute of Mental Health was created in 1949 with a mission of researching, treating, and preventing mental disorders. A lot of you know NIMH today. In the 1950s, you have this beginning of antipsychotic drugs, Thorazine, which was ultimately referred to as chemical lobotomies, lithium, which was introduced at this time to reduce psychotic symptoms. And again, you have this idea of like, I think something that's important when we talk about human history is sometimes there's this concentration on how do we cure this or address this, which when we talk about that history of eugenics, which is the idea of breeding better genes, right, or doing these things, and I'm putting that in big air quotes, that it comes from that. I mean, even recently, there has been this question of, oh, can we find a way to cure autism? Can we find a way to cure these things and do these things? It comes from that ideology. What we could focus on instead is, as people with mental health challenges or these direct experiences instead, the idea of how do we focus on a better quality of life, a better quality of community care and support, rather than trying to cure it, rather than trying to address it. Because a lot of these aggressive treatments and human rights violations come from the desire of, how can we get rid of this immediately? How can we do this? And that's why you have these human rights movements, because then it's like you're treating me as disposable. You're taking me off of the streets. You're saying I can only function in this way, or you're saying I can't function at all. And that's at the very root of it, at least when we talk about mental health peer support, mental health care, the creation of community behavioral health centers, And any community program you work in today, none of those things would exist without the Olmsted decision, which again was the right to live in community desegregated from institutions. The Olmsted decision was realized in 1990 after a woman named Lois Curtis was institutionalized in Georgia for 11 years, and she fought for her independence and spoke out, in front of the United States Supreme Court. And the United States Supreme Court said, how many people are we segregating in these institutions on the basis of disability, on the basis of these things, which is a form of discrimination when you say on the basis of. That's the very foundation of the United States today. So it's the consideration of like, when we develop behavioral health services and we do these things, is there a pursuit to sometimes target people on the basis of something? Or is it the pursuit of offering far-reaching, compassionate community care? Because those are two different things. So just broad civil rights history, you have the freedom fighter, or the freedom riders, like Rosa Parks and many others, who are engaging in civil disobedience in the 1950s. The reason why this is important is because these are early instances of people speaking out against things being done to them on the basis of their race, on the basis of their gender, on the basis of several other things. So for a lot of you as peer supporters, and show of hands, how many of you are human rights officers also? A few people are human rights officers. So, there are 6 fundamental rights that you learn in your training as a human rights officer. Or if you've taken your peer support training, sometimes you hear about like movement history and a lot of these things. And the reason why is that you have to work from a place of honoring those civil rights first. Because again, if you are discriminating on the basis of someone's gender, race, disability, or something else of that nature, it ends up being a violation of the very fabric of civil rights that have been established today. And I think in behavioral health care, we work with people primarily. So I think understanding that at the very foundation, human rights has to be in the center of your work. In the 1950s, there was an institution in Texas. This institution was actually called Rusk State Hospital. Sometimes it was referred to as the Texas Hospital for the Negro Insane. And there was a rebellion that was led by a Black inmate named Ben Riley. And the reason why this is important when we talk about history of segregation, history of civil rights, the reason why there was an uprising in this institution was because Black inmates were being beaten. They were being deprived of food and water and regular exercise. And there were white inmates on the other end that they saw did not endure the same treatments. So that's why there was an uprising and they spoke out. Ultimately, this is one footnote in what led to, really broadening the question of, oh my goodness, segregation in institutions, segregation in our society. This has to change. Yes, and then here's actually a picture of Ben Riley. He's gesturing at someone who has been beaten. And again, there was this uprising. Eventually, there was a bargain with the Texas Rangers, which ended the uprising. It led to some type of agreement on the terms that the inmates had. I don't know how many of you in your peer support training were taught that we don't grow in a comfort zone. We grow sometimes when we're uncomfortable. I know a lot of this information can be uncomfortable. But I want to say in that same vein that the growth and the ideas and the things that you're talking about, there's such a wide array of behavioral health services that you all offer and do. And I think instead of fixating on, oh my God, what awful history, it's actually more, what can we do to continue that momentum for human rights and peer support work and broadly in behavioral health. 1963, this is when, brought the, we have Kennedy here who brought the Community Mental Health Centers Construction Act, which allocated federal funding for community mental health centers. Here we have political activist Tom Whittick and union organizer Dorothy Weiner and unhoused advocate Howard Geld, or Howie the Heart, who organized this group called the Insane Liberation Front, also known as Mental Patients Liberation Front, which was the first known organized self-help advocacy ex-patient group dedicated to liberation from the abuses in psychiatry and the broader psychiatric system. This marked the birth of what's known as the Consumer Survivor Ex-Patient Movement, 1969. 1970s, the American Psychiatric Association conference, gay activists protested the conference by chaining themselves to the door and yelling at the psychiatrists for pathologizing homosexuality and making it a diagnostic category in the DSM. Homosexuality was declassified from the DSM in 1973, though I will say the DSM has held and tracked a lot of behaviors on the basis of someone's sexual orientation. For example, until 2013, asexuality was categorized as sexual dysfunction in the DSM. So you have a lot of different forms of sexual orientation that have been pathologized in the Diagnostic and Statistics Manual. There have been 5 editions, they're working on 6. The first DSM had 150 categories. The current has over 350. So it's grown a lot over time. It's Madness Network News, which was basically a zine founded in San Francisco in 1972. Was started by 2 women who were inmates of Agnew State Hospital in upstate New York, Tulia Tesaro and Jennifer Gleifsner. Madness Network News started as this quarterly journal. Initially, it was called an anti-psychiatry journal, and I think there's one thing I want to name about movements around anti-psychiatry and all these things is that there are some people who have gone anti-medical system as a whole, right? I think that there's fair criticism of the mental health system today that is balanced and looks a little bit different. But I do want to say at the time, this is an immediate response to institutional abuse that is happening up until the early 1970s. So saying we stand against this completely from a group of ex-inmates who were abused in these institutions, I think it's a fair conclusion. So in the 1970s, you have early activists like Cookie Gant, who founded Mind Freedom International, which is a mental health rights organization that does a lot of international work. You have Judy Chamberlain. She was a researcher, psychiatric survivor. She wrote a great book called On Our Own. Basically, at this time, there are a lot of different groups emerging around the country that are called mental patients liberation fronts. Then there are some people who identify as consumers, who are consumers of services. Then there are some people who identify as survivors of the psychiatric system. Then you have some people who identify more as ex-patients or ex-inmates of those institutions. And each of those roles served a different purpose. Consumers were more along the lines of, we can reform the mental health system, we can make change from within. The consumer role is what really led to the creation of the certified peer specialist or certified peer supporter role that we know today. In fact, the term consumer has been switched over to peer in many different contexts. There are a lot of people who identify more as survivors. They more felt about just speaking out about their story, really speaking out against the psychiatric system. Something that I want to say about ex-patients and survivors, some of them didn't want to engage with the system at all. So that in that aspect, you had a lot of people who were like, we can't build here. There's been too much harm done here. So we have to build on our own. And in some ways, people did that. Some people worked towards privately funded grassroots efforts. Some people went with no funding, and there were peer support groups in basements of houses, in local parks, community spaces that they could use for free. Because in a lot of ways, there wasn't enough out there. So fighting for this was so important. National Institute of Mental Health, we have in 1977, the Community Support Program opened its doors to consumer-based programs. That same year, Rethinking the Needs. In 1976, the Network Against Psychiatric Assault and Women Against Psychiatric Assault organized what was called a sleep-in in the governor of California's office, Jerry Brown. That sleep-in lasted 30 days. You had former inmates who were like, hey, there's not enough services, and they're like, we're not leaving. We're gonna set up our beds here. We have plenty of food and water. You can come and go, but we're not leaving your office. It's gonna be hard for you to work. We're gonna make you uncomfortable because you made us real uncomfortable. So again, that sleep-in lasted 30 days. A parallel history too, you have the 504 sit-ins, which you might be familiar with from the disability rights movement, where that was the longest occupation of a federal building in United States civil rights history. This is a state building, but it was the same amount of time. They're both 30 days. The 504 sit-ins eventually led to the creation of the Americans with Disabilities Act, signed by President George H.W. Bush. So after meeting with Governor Brown for 3 hours, he was still unwilling to negotiate. He had 100 protesters, then a 60-person march at the Secretary of Health and Education and Welfare's office. Just some pictures for you all to appreciate. These 1976 demonstrations represented a real unity in the consumer survivor expiation movement. Governor Brown and the state of California never met the demands for the right to refuse treatment. So the demands were never met. The right to refuse treatment is something that is so important today and is a right that I think sometimes we take for granted. 1980s, you have the development of so many different things, Mental Health Consumer Association, National Association of Psychiatric Survivors, who have different core beliefs about how to go about a lot of these things. Again, that's reform versus reforming something that hasn't been working isn't great. So a lot of discussions around that. There's the establishment of the National Mental Health Consumers Self-Help Clearinghouse. 1986, you had the Consumer Case Management Aid Program in Colorado. This was the first known peer support role that wasn't called a peer support role yet. It was called the Consumer Case Management Aid. 1990, you have the Americans with Disabilities Act being signed into law, as we're talking about. It's important to note that both consumers of the mental health system and people in the broader disability movement were present on the White House South Lawn for the signing of the Americans with Disabilities Act. In the prior presidential administration, I actually got to go to the Americans with Disabilities Act anniversary at the White House on the South Lawn, the very place where it was signed. It was a meaningful moment there with disability activists and other peers and people with lived experience in our broader community. In the 1990s, National Institute for Mental Health awards this grant to the state of New York. And that's when we see like the first peer role, it's like certified peer specialist role emerging. You have the establishment of SAMHSA. I'm sure a lot of you know SAMHSA, the Substance Abuse Mental Health Services Administration, the federal agency for mental health and substance use recovery. You have this idea of mad pride. There were some people who really wanted to reclaim the term mad, similarly to how the term queer was reclaimed. And the idea was basically celebrating, having pride in who you are. You know, you have mental health awareness, which sometimes focuses on just be aware of the conditions and what's going on in the community. Mad Pride was this instance of like, let's celebrate who we are. Let's speak out. Let's live unapologetically. So that was in the 1990s in Canada and in Europe and here. You also have Disability Pride, which is in the same month and around the same time, intentionally. And you know, Disability Pride also happens around the time where the ADA was signed. So between 1955 and 1994, 91% of psychiatric hospital beds were eliminated. Much of the funding associated with mental hospitals was not reallocated to support community programs. That's a key part. You had the closing of a lot of these institutions, but they didn't reallocate the funds to the community. A lot of it was upheld. And I'm sure many of you know this, but in most hospitals and institutions that bill to insurance per bed, that can cost an upwards of $2,000 a night. Whereas a lot of community initiatives, you're looking at maybe $100 to $300 a night. The cost margin is way different. So it's interesting from a state investment standpoint. I think it's because insurance companies want to bill for the beds. They want to keep these spaces full. I think hospitals and administrations and boards have this mandate to keep the beds full. It's the same thing in other congregate settings and correctional facilities. They have to keep the cells full too. So, because they bill per area that's full, and if it's not full, why would you get the funding? So that's a big piece. So it's interesting that between 1955 and 1994, we're talking 40 years here. You know, you have this 91% reduction in beds, but no money for the community. Where did it go? So it's an important question. You might hear the term neurodiversity, which is meant to be inclusive of people who have a wide range of experiences, whether that's mental health, sensory, disability, or otherwise. That was coined by Judy Singer in 1998, an Australian sociologist. 1990s, this is when we get Olmstead. It's very important to name that both Lois Curtis and Elaine Wilson filed this lawsuit together. And it's important to again name that Olmstead, you know, came to be in 1999. So again, recent history that we actually have a civil rights law that says that on the basis of your disability or mental health challenge, you should not be segregated into an institution. Is that law always followed? That is up for you to decide. I don't think it is always followed. You have signs such as these, like Housing Not Haldol, which is the end of the decade that brought increases in the percentages of people diagnosed by psychiatry among the unhoused and incarcerated prison and jail populations. These increased rates, so I think it's important to name that when psychiatric institutions closed, prisons and jails started to fill up at the same time. So I don't know how many of you are advocates for things like help not handcuffs, getting people out of like prisons and access to mental health care. You might not always ask the question of if it's voluntary or involuntary. You're like, I just want them to have access to care. So from that perspective, when we talk about closing institutions, then the community investment not happening, then people ending up in prisons and jails, that's an overall issue. And that's an issue that continues to happen today. There's so many people who are wrongly in jails and prisons who could have access to mental health care in the community if it was broadly available. So we have a Surgeon General's report on mental health that introduced the report against the backdrop of growing awareness in the United States and throughout the world that the immense burden of disability associated with mental illness The report also briefly mentioned disparities, but focused on stigma as the biggest obstacle. So mental health stigma, mental health discrimination. Georgia had the first state certified peer specialist program. And then I have Massachusetts history here because I trained the Massachusetts Certified Peer Specialist Training Program. We actually do this history during the training. And that training came directly from Georgia initially, from a group called the Appalachian Mountain Group. So, and we've trained it ever since. And I think it's been very important having certified peer specialist training in the context of mental health in Massachusetts, because we had the earliest institutions in the entire country. When I was talking about that Worcester Lunatic Asylum, that was in the 1800s, early 1800s. I mean, the very beginning of colonization in the United States started in Massachusetts. So that early history is so important when we talk about mental health. And I think that's one of the reasons why our peer support movement is so vocal about a lot of these things, is because we have such a long history of pain and suffering and human rights violations that have happened, that we've seen, and things that continue to happen today. Today, the peer support movement is closely aligned with disability rights, disability justice, recovery movements, and peer support organizations are found across the United States and the globe. So you can applaud that. I think that's great. I know my time is till 11:50 and it's 11:43. So let's start having some questions. I want to say just briefly about Kiva Centers, where I work and the work that we do in Massachusetts. We operate 3 peer-run respites. We do state certified peer specialist training. We do mobile peer respite, so people who can't get into the peer respites, we go to them. We support them for up to 4 hours at a time, multiple times out of the week. We have recovery learning communities, which have peer-run drop-in centers across the state. We do peer support groups in 100 cities and towns, and coffee shops, libraries, a wide variety of places. We do a lot of work in the community. So that's just Massachusetts, much smaller. I think you could fit maybe 10 of our state in this state easily. But I want to highlight that work, and I see you all making a movement towards doing more of that community work. And I wanted to put that on the table because we just talked about this history. Now let's talk about moving forward. What are we doing now? All right, taking hands, questions. Thank you.
Hello. So one of the questions I have, I do see this a lot in California, is even though we passed legislation for paying us a decent wage, it's being thrown to the counties aren't doing it. I mean, we're starting at the same rate as In-N-Out, I think. So I was just wondering, in Massachusetts, are you guys having the same kind of issue with not being able to pay what we are worth, so we can all better our lives as well, so that we can have less stress, so we can do the work that we do?
Absolutely. Thank you. Yes. Appreciate that question. The answer is yes. We do still have those issues. We have a Massachusetts Peer Workforce Coalition, which is in our state, we have certified peer specialists, peer recovery coaches, which are a separate state training. And then we have family partners, we have young adult peer mentors, we have certified older adult peer specialists. So we have a lot of different, and then we have forensic peer specialists. We have people doing many different roles at different agencies. So, and community health workers. So we have a coalition that encompasses as many peer support and lived experience professionals as possible. I like to emphasize, because not every lived experience profession is peer support. Our coalition has been working towards better salaries, pay rates for peer supporters. We've had the discussion of such a wide variety of things that need to be done. The billing to Medicaid, one of the reasons why there's a movement towards that is you can pay at a higher rate by doing that. One of the challenges is maintaining the integrity of the work while you do that. In our state certified peer specialist training, we do co-documentation as a module. I prefer to call it community co-authoring, which is basically like asking the person you're supporting, you know, we are tracking some of these things, you know, because of our requirements. What's the story you want to tell? What do you want to say? And really starting from there instead of following a clinical documentation practice or modality. I think not doing clinical documentation, I can understand why people push against it and speak out against it. There's this thing called the myth of the paper self that follows you everywhere you go. When I was 16, I was attacked, and I ended up in a hospital, and I was questioned by police because of the situation, and they actually thought I did it to myself because of my history of suicide. So that paper self followed me, right, to a situation with the police. So that happens. That's one of the reasons why it's like, you know, oh goodness, maybe I don't want to say a lot about myself or share a lot. I think that there's an integrity in the way that we do it, this community co-authoring approach, what we want to say. Anyway, going back to your original question. Pay rates, huge issue. Some peer supporters in the country have unionized for that issue. Unions have presented opportunities, benefits, challenges. Some groups have gone under existing unions, and that works. Some groups haven't done that at all, and they've stuck with how can we bill or get contracts, or you know, write the contract or the RFR at a higher rate of pay in the budget. There's a lot of ways you can do this. So that's just a few. Great question. Anyone else? We have 3 minutes. Thank you.
So I have a question as a peer advocate, how we can support when we see disparities. Like when we talk about the Black and brown children within our care that have that defiant oppositional defiant disorder at a much higher level. How do we support with that so people at the clinical level?
Yeah, I mean, that's, in a lot of ways, that's systemic. You have to readdress a lot of things. Who is working with these youth? What kind of experience and training do they have? What kind of life experience that sometimes does have a level of implicit bias with it? So I think that there's a few different factors there. I will say that ways in which you can support is if a child or a youth is then being diagnosed with oppositional defiance disorder, I think it would be important to either with a treatment team or the professional as an advocate, and again, it has to be with that youth, young adult's consent and parents' consent if that's the case, right? Be able to come back and be like, hey, like, can we revisit this? Can we discuss this further? I understand so-and-so manages, you know, a lot of these issues in this way. And I think maybe, let's say if it was related to school, maybe they might not be paying attention in school or doing these things in school because this is how they're being received or treated in the classroom. Tommy, let's say their name is Tommy. Tommy's the only Black or brown kid in the class. Like, has that been considered in the conversation? We have an approach in our certified peer specialist training. It's called power, conflict, and integrity, which means addressing the power of the professional, saying like, I understand you've been working with Tommy for quite a few years, and I appreciate the work you've done. Our conflict here, right? You won't say the word conflict, but you'll say like, one of the things that we're kind of struggling with here is the fact that he's been, you know, labeled with oppositional defiance disorder, and this is his environmental setup at school or at home. And then the final thing is the integrity. Is Tommy in the conversation? Is his family in the conversation? That's the approach. Yes?
Okay, so this isn't really a question, but I just really wanted to say thank you for all the work you put into presenting this to us, because I feel like as society is progressing and there's just so much going on in the world right now, sometimes we can feel kind of helpless in the chaos and, like, what can I do? I'm just one person. But I feel like in going through all of this history, as grim as it could be, I see something so beautiful. I see progress. I see change. I see people who have been at the lowest point in their lives, yet they have adapted. So I feel like this is very inspiring for me, because it helps reignite that fire in me that I really do have power, and we all have power. And so just thank you very much for this beautiful education.
I appreciate that. I want to say briefly that to view the work that you do today as a legacy of that work is an important piece. That's the way to move forward. Sure, maybe you might have so much red tape. You might be bogged down at the very depth of bureaucracy. You know what I mean? Like I'm working in a state-appointed position. I have to be very careful with that. I can be fined $10,000 if I step out of line. At any point, I signed some intensive agreements, right? Intensive bureaucracy, intensive things that exist. We cannot slow the momentum. I think sometimes you have to be willing to work and operate in a certain way in a certain space. And then sometimes the conditions demand something else. And you have to ask yourself, what is the conditions of what is happening right now demanding of me? Demanding of our community. Thank you.
Not actually a question either, but I'm glad that you implement that. How there's been institutionalized, or things that are still going on around the Black artists, everybody. That you implement that in your training to support. Hopefully, everybody can implement that so people know the right to mental health and all that, and all the aspects of, it does still go on and it does start, with that. So I did like that.
Thank you. I do it because I stumbled into peer support. I stumbled in. I didn't have it when I was hospitalized. So I got out of the institution. I was on a lot of medications, managing life. I actually wanted to become an artist. Checked out a few different mental health programs. I wanted to do like an art show or a gallery for a mental health program. I had my degree in public health. I'd done some of that work. But now I'm like, oh goodness, what am I going to do? And I didn't really want to I was like, I want to work in these environments, but I'm not sure what it looks like. I didn't know that the peer specialist or peer support role existed. So I didn't have access to that. All my cousins, people in my neighborhood growing up, one of my cousins, Juan, he's serving a life sentence in prison. So my uncle also served a sentence. Had to visit him when I was a kid. So I didn't really have that inspiration for community healthcare and care growing up at all.
So like she said, it's a little different, but we have to, especially when you have other experiences, but I do it because I do like other people, and like you said, it's a lot, not just everybody. So.
Do it from that place.
Yeah.
It's an important place. 5 minutes, thank you. So yes, see your hand in the back.
Thank you very much for being here and giving us all this amazing information. I've been in the field for about 17 years now. And one of the things that I heard you talk about is that stigma that we as peer support specialists face pretty much every day in the work that we do, whether it's working with others, working with clinicians, or working within the system. For you, have you seen a benefit for us as peer supporters to be able to do a training for the clinicians on what it is that we do to get them caught up to our expertise?
Yes. There are a lot of benefits, and I have done a lot of trainings for managed care organizations across the country that usually have clinicians or clinical professionals on their teams attend those trainings. And I usually apply for CEUs, whether if it's at the, we're talking National Association of Social Workers, LMHCs, otherwise. And, pay like, whether if it's like a couple $100, get those CEUs together, pay it out of a contract, establish a contract with a managed care organization, and then start doing like a 101, like this is what the certified peer specialist role is. I do cultural humility trainings with a lot of them, and other trainings that they request and doing work on the field. And it helps them because they work on these integrated teams with peer supporters and they don't understand the role, and they're like, well, I studied in school for like 6 years, and like, why is this professional coming in out of nowhere, and why can they just talk about what they're going through? I think that there's a level of, sometimes I think that there's a level of envy, and I also think that there's a level of concern too, where it's like, isn't that crossing boundaries? All of my training says don't do this.
Yeah.
All of it. So it's like, teasing it out, doing those, there's a massive benefit. And highly, highly, highly recommend that you do more of that here. 3 minutes, thank you. So I wanna, do we have another question? Yeah.
This might be a little touchy, so you don't have to go too deep into it if you don't want to, but with the current climate of the world, where do you see like the mental health movement, the peer movement, all of that going in your perspective?
Yeah, thank you for that. There's a lot happening, and I'll just be candid. It's difficult. I think human rights are nonpartisan. I did a speech in North Carolina, which is a purple state. So we got a lot of people who are in the red and a lot of people in the blue. Everyone talking about different things. And I said, sometimes you gotta hold your morals above your manners and speak out about what's right. Because if you don't do that, a lot can move, right? I think that's, sometimes we have to get to that space. We have to get really real about the true impact of all of these things. There might be people who say, oh, well, we impact too quickly. We did all of these things, like I don't fully feel included in some of these spaces. Or I don't feel like, and there are these kind of cross-community dialogues that need to happen on the community level, even if they're not happening on the federal level or the state level. In terms of advocacy, it continues, right? So the Department of Health and Human Services, recently the secretary had said a few things about autism, the need for curing autism, this and that. And so I was asked to go to a meeting to meet with the secretary and his team at the Association of Persons with Disabilities in Washington, D.C. And I went. He didn't show up to the meeting, but someone who worked under him, Mary Lazar, who was the head of Adult Community Living, did, and told her exactly what I had an issue with. The situation demands that of me. I'm a constituent of theirs. My tax dollars pay for them, and we work with the communities that support their families and support the very fabric of this country. So in terms of where I see our movement going, I see it continuing. I see that there's going to be difficulty and sustainability in terms of government funding at times. I do think that there will be some tenacious and innovative change, and I think that there will be people who will dare to do more. I'll leave on that note. Thank you.
Thank you, Vesper. That was great and refreshing, and I think a message I think we all need to hear right now, right? What's going on? System changes, things that are going on nationally. There's a lot. So we thank you for traveling so far to see us and sharing your word with us. Sorry, I didn't know my kids would all right, so I have some quick
lunchtime announcements. Of course I do. So how to get, or wait, before I say how to get your lunch, I did want to just touch on a couple things. One of the things, Vesper, that you mentioned was friendship. And I have a sibling who gets full service partnership services in our county. And I did a focus group maybe about 6 months ago, and it was around outcome-based payment. So we only pay you if you get outcomes with the folks you're serving. And they asked me as a family member of an FSP client, like, well, what would you want? And I was like, friendships. You give her medication all day. You can come see her every week. But what social interactions does she have? What connections does she have? Who can she call if she's having a bad day? Where can she go and feel safe and engage with people? And so I think that that's a huge, important component of recovery. And it's not something that I think we talk about enough. We kind of like zoom in on like manage the condition, like, you know, let's reduce the symptoms, let's like get them a job, let's, you know, do these other things. But human connection is so important. And anytime I hear someone talk about that, I just have to say how important that is, because that's what I want for her, is friendships, right? We don't talk about romantic relationships. We don't talk about all of these things that we all have and we take for granted. And so I know you already preached to the crowd, but I just had to throw that in there about that, how that really touches my heart, because it is so important and something that I think we see every day. And when we see that need in the people that we are closest to, it's like we want to fix it, but how do we fix it, right? If we can't change how our community looks at these topics. So I really do want to thank you for that. I think it's just so important to keep in the front of our mind is we are dealing with people, and we need to recognize what those people first needs are. Okay, so I'll get off the soapbox now. How do you get your lunch? So your lunch item that you selected in registration is on the bottom right of your name tag. We are asking that you stick to what is on your name tag because people selected their own lunch item, and I know if someone's like, I was the first person to register and I didn't get what I wanted, you know, we don't need no brawls in the line. So if you were a late registration, a walk-in, or added from the wait list, please just hold on a moment. I know we have more lunches than we have people, but we just want to make sure that folks who did the early registration are able to get their lunch selection. We do have 2 lines, so you can come on both sides of the table. I hope that that speeds things up a little bit. And then we have drinks on this side of the room as well, because we know that held the line up last time, so we hope that helps. One thing I didn't mention is in the far right corner, we have an art table, and I think that's where you brought up like art as well, right? And so the things on that table were actually created during some of Hope Cooperative's art groups. So folks who are participating in services in our county were able to produce that art. And then on the easel is an art piece from one of the Stop Stigma Sacramento artists that really did art display during the month of May. So we really want to encourage you to check that out. We still have our outside activities, a photo area, so we want to encourage you to take advantage of that and network and make friends and get to know each other, because I don't know when you'll get to see each other again in person. So highly recommend. We are going to start back promptly at 1 o'clock, so I do want to give you your time back. So feel free to get in line, and then we'll see how it goes. So good luck.
So I don't know if they're lying. I know. Hold in here.
Yeah.
At our commission. So we are. I would say like part of the professional I actually, I'm gonna go meet you. That's great. Yeah, so I'm gonna meet you. I'll be back. I'm gonna come back.
I know, right?
If you are waiting and have not gotten your lunch, please go ahead and get in line. Thank you.
It's okay, I'm Donna. It's really nice to meet you.
Yeah.
Did you get your lunch?
I'm gonna get it right now.
Okay, we have the lunch over there and then drinks and stuff right over there.
Oh, lunch over there. Okay. that's
I'm gonna
all
run
right.
to the bathroom, but I'm
Okay.
so happy you made it.
Okay, did you get my text?
Yes, thank you.
Okay.
Thank you. Yeah, enjoy your lunch, and then I'm gonna check in with you before the panel.
And what, it starts at 1:30?
Yeah, it starts at 1:30. It starts at 1:30.
I'll talk to you in a little bit.
Thank you. Okay, I'll go around that. Okay. Thank you. Of course.
Friendly reminder, if you have not gotten a lunch yet, please come up here and grab what your best choice will be.
You gotta hug her.
I don't need anything from you right now. Okay, yeah, music was fucking. Oh, okay. I mean, yeah, no, that's cool. I was organized. Okay. Okay. And there's no back to back. Okay. Okay. Thank you, Sam. Yeah.
If you can hear me, clap once. If you can hear me, clap once. If you can hear me, clap twice. If you can hear me, clap 3 times. You may notice that there's a line forming on that side of the room because there are cupcakes. So if you would like a cupcake, please head that way. If you are gluten-free, not by choice, then please make sure you see Robert's raising his hand. People, we have gluten to the side, gluten-free to the side. So there are not a lot of them. So only if you're, not gluten-free. If you're gluten-free, not by choice, we have them for you over there. Otherwise, please enjoy the dessert. We'd love for you to take them home so we don't take them home. Thank you.
I'm not really sustainable wellness interview. Ross and all the CWC care, and I know you know. So we have this nice have that reminder.
All right, everybody, we're gonna welcome everyone back and get started again. We are trying to be as on time as we can be to ensure everyone gets out here on time. It's a Friday, I don't think anyone wants to leave here after 4 o'clock, so we are gonna do our best to get through the rest of our agenda. We're just gonna give a couple of program updates of where we are in our program. A lot of you have participated in a variety of our activities, whether it be our employer trainings, our community education courses, our learning collaboratives, our conference last year. Some of you have participated in key informant interviews, focus groups, listening sessions, and things like that. So we are just want to kind of give folks a little bit of an overview of what we've been doing in the program. I had already introduced myself, but I do want to introduce Nicole Scanlon, who is our peer sports specialist liaison representing adult family members. Nicole has done a lot of the behind the scenes stuff. So this year I was like, you're getting on the stage. Nicole designed our conference programs, your name tags, the evaluation cards, anything that you're seeing that visually looks like someone had to put it together. That was Nicole doing that work, so we are very appreciative. And so, do you want to say anything?
I just want to thank everyone for making this morning a wonderful check-in process. Without you, I think it would have been all chaos. Thank you.
So if some of you have not or are not too familiar with our program outside of the conference, we do offer 2-hour continuing education courses for certified peers twice a quarter. And we also provide 2 90-minute webinars for employers, two of them per quarter as well. So not only do we recognize, like, one, our peers need ongoing training, education, get those continuing education hours for free. But also, you know, things don't necessarily work and fix themselves when we're not really looking at like a top down, bottom up, everybody's meeting in the middle, right? So that's one of the things that we really thought about a lot in designing this program is we can teach peers all day, but if we don't have decision makers in organizations, managers, leaders, supervisors, also learning and being able to make change at that level, then we kind of don't really see the change that we want or that we put the effort into. We do offer monthly learning collaboratives. You have a flyer on your table. We will be having one next Friday, and the topics, we're actually going to focus on what we talked about today, because there was a lot of information shared with you. There were a lot of questions asked, but there isn't a lot of room for discussion in a conference format, right? So our learning collaborative is next Friday, June 6th. If you are interested in participating, we welcome you. We welcome peers. We also welcome peer employers. We do offer the Learning Collaborative once a month, so it's typically on the first Friday of the month, and it will generally follow the topics from a previous training that we did to give people just more time to talk through things, troubleshoot. But we also offer anything else. So if there is something else that is going on where you are wanting a little bit of TA to talk through things, either as a peer or an employer, we welcome that at the Learning Collaborative as well. We are not limited to the topic that we put on there. We just want to have a topic so people feel like, okay, I want to go to this one because they're talking about this particular issue. We also do an annual peer employer survey, which will be coming out in June. So we want to encourage you to keep an eye out for that. We use that information to really figure out like what are the training needs we might want to consider addressing this coming year for both employers and peers. Are there any TA needs? Like, are there things that you're doing amazing in your organization where we want to share that information with other providers? That survey is really to collect information from you so that we can make recommendations to the county, but also make adjustments in our program to ensure that we are actually meeting the needs of our local peers and peer employers. A couple things that aren't on this list is that there is also a employer focus group scheduled for June. We actually have two of them, one for the adult system and one for the children's system. And so that's where we're wanting to hear from like managers, supervisors, HR, agency leadership to really kind of give us feedback on like where are you having challenges, what's working, what's not, so that again, we can tailor what we're offering. And so if you're getting emails from us, that's why. We want to know what you need so that we can respond appropriately, and you also feel like the feedback that you're giving is actually being reflected in what it is that we're providing to you. And then we do offer consumer listening sessions, really focused on peer support services. So if you have peers in your organization and you're like, well, we kind of want to figure out how this is going, like how are our service participants engaging with them? Is it working? Are there things that we might need improvement on? And so we have a virtual listening session scheduled in June. So we really do encourage you to share that with the folks that you're serving. We do want to get that input, and it does, again, really guide us in the work that we are going to be doing in the next fiscal year. And we also reach out to providers, and there's a flyer for this, for you to host a listening session. One thing that we've recognized is that we have a lot of people in our system that don't have reliable transportation, right? We're like, we're going to do this focus group at this site. Everybody meet us there at 2:00. And it took them 3 hours to get there, right? That's a reason not to go. And so we've been working with a variety of organizations, including Bay Area Community Services, Hope Cooperative. We've worked with Heartland. We've worked with quite a few organizations to go to them where people are actually at to provide those listening sessions. We do raffle off a gift card, and we do have vouchers for haircuts. So we try to, bribe people to come. But we will come to you. So if you're interested in hosting one of those, there's a flyer there as well. And then I have Nicole up here because Nicole's awesome. But also we have a peer toolkit and a peer employer toolkit that we have launched. There are some little QR codes in your activity bucket that you can pull out, scan them, and it'll link you to the toolkits. We will also be sending an email blast out about those, but they're really intended to support peers in their careers, peer support specialists, but also support employers. Like, how do you write a job description? How are we evaluating performance? If somebody needs like a little like tip, like how can we create a collaborative work plan with somebody so that they're successful in their job? So we're really tailoring those toolkits, and the information you provide us, the feedback you provide in those various avenues that I mentioned, we use all of that to determine what goes in those toolkits, what goes in the trainings that we're providing. And I just want to hand it over to Nicole because Nicole actually designed our toolkits, and they're very, very inclusive of a lot of information, and it was a heavy lift. So I just want to hand it over to Nicole to give a brief overview of those.
So this year's toolkits are much more interactive. You all get these toolkits, and then you download them, and all of a sudden you have this 160-page PDF. Maybe it has a clickable link that takes you to this page. This year, we did things on FlipSnack and Canva, which allowed us to actually implement videos. So now there are videos. So if you're just wanting some general information, we put our latest and greatest videos in there. Not ours, but ones that we like. On different topics. I think there's one on HIPAA, for example, if you're, in terms of confidentiality, right? It's a real short video from YouTube, that lets you understand what HIPAA is about. We also do like just really short 15-second clips. So we're hoping that will help increase interest in looking at the toolkit, but also provide you with some valuable information. As Stephanie said, we do take all the information that you give us through the various events that we have, the comments that you make in trainings, and we do put that into the toolkit. And we go ahead and we put relevant information that you have said that you need as peers. And the same thing with the employers. In our one-on-one conversations with employers and our learning collaboratives, we get feedback, and therefore we then put resources and information in the toolkit about that. So a lot of the content that we have is based on evidence-based practices and the feedback. So for example, this year's toolkit includes a lot more on documentation skills, because one of the things that you all told us, whether you're an employer or a peer, is that you want to know more about documentation. Now, while we can't help you with SmartCare, because that's not what we do, we can tell you the general framework of peer documentation and what CalMesa suggests, and sort of help guide you with examples. So this QR codes are up there for the toolkits if you want to scan them now. As Stephanie said, there are little cards in your wellness goals. However, we have some extra that I will put up at the registration desk. So when you're on your way out, if you want to pick one up, then you'll have it at your fingertips.
Just a couple of things we wanted to share that we've been doing is that we know that not everybody can show up to a training at like 10 o'clock on a Thursday because y'all are providing services, right? So one of the things that we have done is we have taken our live trainings, recorded them, and then put them into our online learning management system. Originally, they were going to go on YouTube, and we decided we actually want to offer CEs, even if you watch it outside of that live session. And so by putting it in the online learning management system, we had a couple assignments, because you're not in the rest of the discussion that we might be having, but you are able to get continuing education hours through our online learning system. And after the conference, we forget things, so we will send an email box out probably sometime next week with just some of the information that we shared today. So you will get that. You don't have to write everything down. But we do have currently 20 available courses. We have a 3-hour ethics course. We have a collaborative communication course, a documentation skills course, a lot of them. And so if you are needing CEs and you're like, my renewal is in 90 days, definitely want to encourage you to jump on those and get those hours done. And then Nicole actually built and monitors our online learning management system. So if you were to email and interact, Nicole would be the person that you'd be interacting with. So don't be afraid. It's just us. We welcome you to that. I did mention a listening session, so that there is a flyer on your table for that. And typically what we do is we connect with a provider, and they tell us like what's the best space to use, what time is best for the folks there. So for an example, we did it at one of our local wellness centers, and they had said, come at 10:30 because we do lunch at 12. People get done with their laundry around 10 o'clock, and people will be here. So they've told us, hey, come to this place at this time and you'll have people. So so we really work closely with the provider to find out like what's the best plan there. We host the listening session for about an hour. We ask people questions, we write on flip charts, we give them papers and Post-its and stuff. If they don't want to verbally participate, they are still welcome to participate. And as mentioned, they do get entered into a raffle, and we, at least for the next probably 5 listening sessions, we have those nice haircut vouchers that you have in your swag bag that you got today. Maybe you didn't notice, but there's a haircut voucher in there. I cut my hair in the bathroom over the sink, but there's a Smart Clips haircut voucher in there, and I'm like, maybe I'll go get some layers. So you will get to enjoy that great service. Also share it with someone if you like, but we will offer those to the participants that attend listening sessions. We don't want to ask for them to do something for us for free without finding some way to provide, something to thank them for their time. And then does anybody have any questions about what we're doing, what we've been doing, about any of the things that we just talked about? Concern? Testimonials? Thumbs up in the back. Okay, all right, we'll take
Like
that.
a thumbs up. I think that's it.
Okay, I think that's what we've been doing. We will have an announcement coming probably late June for our upcoming trainings. So I think we have one scheduled for, if not July and August, July and September. So we will have at least quarterly, you'll have an announcement go out letting you know what courses are going to be available that month. And then we, again, welcome all to participate. And if not, we do have the non-live online learning management system option for you as well. All right, so we are going to transition a little bit early. We do have a panel presentation. The panel discussion for this afternoon is going to be more focused on like how we are engaging with diverse communities, right? How are we engaging? How are we utilizing our lived experience to engage, right? One of the things that I know Vesper talked about earlier was the authenticity and realness that comes when we actually have been through what other individuals are going through, or if we have come from the same community, right? And so our next panel is going to be focused on that piece, and I am looking for Zana. Zana is going to come. Can you go find Zana? Yeah, Zana's going to come join us in a second. And Zana is our transition age youth peer support specialist liaison, and so is actively involved in the youth advocate committee. And I will tell you, definitely keeps us on our toes in knowing what the most recent trends and language is. I recently found out what lore was versus the T. So, but it has. I can't tell you how wonderful it has been to have such a diverse team. Both in like their intersectionality with their age groups, and like everything has been really awesome in really trying to think about our community really holistically and thinking about the varying aspects of recovery that might be, work really great for other people where other people may need more supports. And so I think just as, for my team, I think this is important. It's really in all of our work. It's like, how are we ensuring that we have diverse perspectives on our teams? Anywhere from how we're providing services, but also like, what does our flyer look like? Right? How many times have you seen a flyer that comes out and it says stakeholders welcome? And someone's like, does that mean I'm getting dinner? Like, what does this mean, right? And so there are a lot of, there's a lot of terminology, there are a lot of ways that we provide services in a traditional system that where our language doesn't really align with like our general community members. And as peers, we are often like the translator between that, right? Taking this very formal system and language and being able to provide support to our community members and helping them to really kind of understand like what is happening here, what are these people telling me, and vice versa, right? Where we are often that cultural broker to our providers, our colleagues that we work with, and ensuring that we are serving individuals in our community in a way that is most appropriate for them and not harmful, right? That piece is really, really important. So as we find our moderator for our panel, I am going to invite our panelists up. You may come at once or one at a time, but I will start to read your bios. So we have Doretha Williams, and Doretha's been around a long time, and Doretha is a visionary leader and bridge builder committed to advancing equitable health outcomes, particularly for African American communities. Raised in South Central Los Angeles, she develops culturally relevant solutions through innovative programs and collaborations. She currently serves as senior pastor and executive director of A Church for All, which houses the Ripple Effect Respite Center. Anybody know that? And the Living Room Suicide Prevention Project. Doretha has held leadership roles with the California Black Health Network, the California Institute for Behavioral Health Solutions, and AIDS Project East Bay, where she helped establish California's first African-American HIV/AIDS state of emergency. She also directed the network of ethnic physician organizations, engaging over 20,000 physicians to address healthcare disparities. Her work consistently elevates the community voices and fosters partnerships that drive systematic change in health policy and access. And I have known Doretha for a long time, and she walks the walk, let me tell you. Walks the walk. And so we are very grateful to have Doretha. So if you want to come up and have a seat. Our next speaker is Marcella Ariza. I didn't say that terribly. Come on up. Marcella is a mental health clinician for Youth and Taste Services at the Sacramento LGBT Community Center. A first-generation Mexican-American and former migrant farm worker, Marcella is a bilingual trauma-informed therapist providing both therapy to the LGBTQIA+ youth. She uses evidence-based modalities and empowers clients with tools to manage their mental health beyond treatment. Marcella holds a BA in psychology from California State University, Fresno, and an MA in counseling from the University of Phoenix, San Diego. Outside of work, she enjoys backpacking, horseback riding, sailing, motorcycle riding, traveling, and helping raise her grandchildren.
I didn't know you guys were gonna do all include all that.
And then we have Gulshan Yusuf. I'm gonna mess this up. Yusufzai. Should have just sounded it out. A refugee from Afghanistan, was displaced to Pakistan due to the Soviet invasion before arriving in the U.S. at age 9. She settled in Sacramento, earned a degree in political science from UC Davis, and developed a passion for community development and social services. Gulshan worked with the California Institute for Mental Health from 2004 to 2008 and served as Deputy Director of the California Network of Mental Health Clients from 2009 to 2012. In 2013, she became the Executive Director of Moss Social Services Foundation, expanding staff, programs, and securing funding. Gulshan launched the first peer support program for Muslims in the United States and was named the 2022 Mental Health Champion by the Steinberg Institute for her leadership. We have a very wonderful, diverse panel. I'm very excited to be able to kind of have this conversation and really have this conversation from the perspective of those who are actually doing this work, right? Who are daily engaging communities that may not often feel safe or empowered when engaging in our traditional system. So we are very grateful and happy to have you three. And I'm going to go ahead and hand it over to Zana, who is going to take over from here.
Hi everyone, I hope everyone enjoyed their lunch. Like Steph just said, my name is Zana Bates and I'm a certified peer support specialist on our team, and I'll be the moderator for today's panel. I'm pretty sure Steph already explained what our panel is about, but we're going to be talking about peer support in diverse communities and speaking more about that. And thank you to our wonderful panelists today. So without further ado, we're going to jump into that first question. So can you each please give us a brief description of your organization, who you serve, and the types of services that you provide? And then the mic should be on, I think.
All right, can you? Maybe.
All right. Hello, everyone. Thank you so much for the invite, and great to be here. I've been in peer support since, been working in peer support since 2004. So it's nice going to any conference, but especially the one where we're talking about peer support, as well as just having individuals with lived experience, because I can connect so much to it and fully believe in it. So. All right, so in terms of question, the organization that we're from and what we do basically.
Yeah.
Right? All right, so I'm trying to catch my breath. At about 12:30, I went to turn on my car and it wouldn't turn on, so I had to get an Uber, and then the Uber person didn't know what she was doing, so I was a little flustered. All right, so Gulshan Yusufzai, I've been with Muslim American Society Social Services Foundation. We're known as MAS SSF. We're a nonprofit basically that's focused on serving the Muslim community, really any community, but we're focused on Middle Eastern, which is like your 20 to 22 Arab countries, Muslim or non-Muslim. So a lot of the Iraqi, Syrians, Egyptians that you see here, and right now I believe Egyptians are, the Arab community in Sacramento is a threshold language as of 2017. Then there's the South Asians, which are your Afghans, Pakistanis, Indians, Iranians, many South Asian countries, and then you have your North African countries, Moroccans and so forth, and actually Egyptian belongs there, not in the Middle East one. Anyway, so a lot of countries, a lot of representation. Pretty much the community we serve includes every ethnicity, including the LGBT community. And so there is a huge gap in that because Mass SSF, I think to my knowledge, is probably one of the few organizations, if not the only in the United States, that provides mental health services, specifically peer support. And so we have 9 programs. It ranges from counseling to communication to refugee program, the first domestic violence shelter in Sacramento for Muslim women, a youth line, many youth program, and it is basically focused and offered in 5 languages: Arabic, the 2 Afghan languages, Dari, Pashto, and then Urdu, and of course English. And all our staff, which we have many staff here, if you don't mind, if you could stand up, I'm very proud how many are here. Thank you. So we have a diverse group of staff, Afghan, Pakistani, Indian, actually Caucasian, and then we've trained over 101 peer support counselors since 2016, since we've been funded by CDPH, Office of Health Equity, to basically design the first program that is community defined. And so when I came into Mass staff after being in mental for a long time, there was a question that CDPH was looking into and asking underserved communities, what is it that helps your community heal? 34 agencies, and we were the 35th one, responded by developing community-defined practice, and it's part of a larger program called California Reducing Disparities. It's the first of its kind in California. It's supposed to get cut soon, hopefully not. But in 9 years, we've been developing this program, us and 34 agencies. And last year, CDPH announced that our program, along with 3,400 programs that are for underserved communities, saved California $335 million in terms of, and this really is relevant to our community because Sacramento has now become the hub for refugees. So in 2021, over 100,000 refugees came, about 36 to 38% are residing in Sacramento. Keep in mind, that's just Afghans, in addition to the Arabs, Pakistani, Indian, and so forth. And so it's a huge number. Of course, data is not correct, and we have about, I'd say, 70,000 plus. But if you just look at the refugees, the way that data is collected, none of it is reflected correctly. But huge population here. Our programs serve in their languages. Our staff are almost 99% of them are from the community, lived experience. Some have just come from Afghanistan like 3 years ago. Some have come 10 years ago. So, and that's a country that's been in war for 40 years, and it's still continuing. Although UN is saying, well, it's not a refugee community, but I beg to differ. Then you have the Arab communities who are always in turmoil in Palestine and so forth. So a lot of communities with a lot of traumas that we're having, and we're serving. Our programs are all designed to have staff that are from the community, speak the languages, understand the cultures, and of course, most importantly, live the experience and offer this to the community. A community that is very traditional in nature and does not believe in going outside of their family to get help. And my over 20 years of experience, and I'll conclude with this, is I had not seen, people come in asking for help. They come and ask for help for everything except mental health. Just in the past couple of years, people are coming in high numbers for domestic violence, anger management, substance abuse, and a lot of referrals from schools for children and youth. And of course, many other challenges that someone who has been born, raised, and gone old in war, and now is in the US trying to start a whole other new life. So that's just a little bit of what we do. Thank you.
Thank you.
Awesome. Okay, that's not testing.
So, hi. Let's see, A Church for All, I think I should start there. A Church for All was founded in 2006 as a church. Most of us had gotten kicked out of churches because we were primarily, say, gender-loving people of color, and we were not welcome in the churches that we were born and raised in, and needed some safe space for us to worship, congregate, connect, share our own spiritual experiences, building community. But the challenge for us was that we had then pulled together this group of people who were high risk for a whole lot of things. Domestic violence, challenges around employment, issues around gender identity, what else? Family issues, suicidality, inappropriate medical care, and we put them all in the building together in the same space. And it was traumatizing for those of us who were clergy in the space, which I'm clergy, and trying to support this community by ourselves. We started reaching out to service providers to then find that there were no culturally relevant services for LGBT folk who were also people of color, mostly Black folks. And we decided that we needed to do it for ourselves. Now, fortunately, I had the background and training and experiences that I had. And we had a few more folks in the congregation who were social workers and psychologists who then pooled our resources together and started training people in the congregation to provide early intervention for the folks who were in the congregation. Because by the time they were getting to us with all of our, we were all working full time. So this is not your typical church folk or clergy kind of folk. We don't go to, in our world, you don't get a job and then go work full time for a church and get paid. In our situation, we were volunteering our time to build this community. So we all had jobs and all of those things that come along with that. And we pulled our resources together to then formulate a peer support and congregations training that we then pitched to the county, pitched to the state, and then went around and CIMH, which is now CIBHS, and ended up training Black churches in how to do early intervention from using congregants, peer support. And that's where A Church for All, I guess, sort of rose to the attention of the county, and then were asked to submit a proposal for an innovations project to keep people out of the hospital. And that is where the ripple effect came from. If you know the ripple effect, you might know that we used to be downtown, across the street from Sutter Fort in Pioneer, that UCC church. But we got kicked out because the community couldn't handle the volume of people that started coming in for respite services. And we were told that we had a choice. We could either give up the services and stay in the building, or we needed to get out. And we said, I guess we gotta go, because this is our calling, this is what we're supposed to do. We had, avid volunteers that were committed to this work, and a community that was committed to us. Because we were a new program, if you know anything about Sacramento, if you're a new program, it is hard to get your roots set in this community. People have to know you 20 years before they start talking about you. So thank you for acknowledging your understanding and relationship with the ripple effect, because we are now probably about, 15 years old or something like that. And so it is about time for us to be in the consciousness of provider community here in Sacramento. And so it really took a grassroots effort to build the ripple effect. And then finally we got the innovations grant to then support our current it's morphed into a variety of things now, but our commitment to providing respite services on the ground. We were part of the last round of respite programs that were funded for people of color, for LGBT community, and youth. You know, that was the round that was for us, which is always very interesting that happens at the end of funding as opposed to being a priority at the beginning of funding. I don't know if you might want to pay attention to that kind of thing in the future. Most high-risk communities ending up at the end of the, funding stream as opposed to, right? So we ended up in North Highlands, and after being kicked out of the church, and had a nice run there for who knows how long, and 8 years. Thank you. And that's Madison. She's one of our case managers, our peer support specialists. We call them peer care coordinators, okay? Because the whole goal was for them to provide coordinated care for the people in the community who could not do that for themselves. So in our world, we get those folks who get kicked out of most of your programs. That's probably how you know us. And then they come to us because they have nowhere else to go. And then we hold their hand through the process of having to reestablish their lives and get their house in order, in a sense, right? That's the work that we do. We were very fortunate to have gotten your support and the community support around this work that we were doing, and the county then gave us the opportunity to apply for an African American suicide prevention project, and that is the Living Room. We started that program conducting a needs assessment within the community, asking people, what does suicide look like in our community? And we quickly found out that the name African American Suicide Prevention Program was going to be a death sentence for the particular program. People were not interested in having that conversation. It is not something that we ascribe to in our own community. As a matter of fact, there's a whole bunch of consciousness around that subject that says, oh, Black folks don't kill themselves. But there are things that we do that then lend itself to a loss of resilience, a loss of hope, a loss of willingness to thrive. And we started looking at those things as we were conducting our needs assessment. And the name Living Room became the emphasis for the program, helping people learn how to live. And this program's probably been up now for about, it started at the beginning of COVID. So 5 years, thank you very much. It's good to have people who are around. I don't think in time, I only think in money. No. So, which I don't have much of, so it's easy, And so this program provides a couple of things, at least three things. Individual counseling to people who are at risk. It provides group opportunities to network and bring people together and provide sort of a community-based support system for folks. But it also builds the capacity of the community to provide the services for itself. And that's actually the goal, is to train the community, to get the folks in the community invested in doing the work that we would normally refer out for, doing that work long before we get there, because we can't wait 3 months for an appointment, And the complexity of the people's lives that we impact in that space require a network of interventions as opposed to, individual counseling and support. We have to be real about that. I mean, there's a whole lot of things that impact our willingness and ability to keep going and to get up every single day and make it happen. And so the Living Room operates across the county, but it has offices we are now in the Tomas, in a warehouse, sort of kind of warehouse, in the Tomas. And we are also located at Rose Family Creative Empowerment Center in South Sac. And so we vacillate between those offices, and then we do a lot of individual outreach to people in the community, and we can talk about that when we get to all of that. But we also will see people in their homes, we'll see people in the park, we will see people at Starbucks, we will see people in the offices. They just need to be able to get us on the phone. And that's, always a challenge. But that is the way that we think about the work that we do. And we can talk a little bit more about some of the cultural relevance of all of that and how we are thinking about developing programs and services that are relevant to the life and lifestyle of African Americans.
I want to ask a couple questions later as well. So I work for the Sacramento LGBT Community Center, and we provide free services. There's a hope, so it's kind of, there's so much. Where do I begin, right? And by the way, I'm a little nervous. I just didn't know I was going to be speaking in front of a lot of people, so bear with me, please. And I'm honored. I'm honored to be here. I love the presentation, the mental health history, everything that is so on and so forth. So we provide. We also we have 2 respites. We have. I'm a TAE clinician in transitional age youth, which is 13 to 24, and then so we have a respite for the youth. And I would explain
Sorry,
that.
Marcella, can you hold the mic a little bit closer?
Like this?
Yeah.
Okay. Okay, thank you. So so we have 2 respites. We have for the TAE 13 to 24, and then we have the adult respite 25 to on up. And I'm just really going to quickly say this is we just lost, probably seen it in the news, we lost the federal grant for that house, and we had a program that was, so 2 clinicians, one, I'm upstairs with the youth, the TAE, and then the one for downstairs, and then we had 2 peer support specialists. Awesome. And I'll talk a little bit about that because I am a clinician, and I heard questions earlier about how clinicians can be trained. I'll kind of give you a brief history of my experience as a clinician doing peer specialist work. So what happened is when they cut our grant, which was in April, like they just one day the next day they say, hey, we had a big meeting. You guys, we're cutting the program, and at the end of the day, we have to leave, right? So it's 2 therapists and 2 peer specialists. It was shocking. It was pretty bad news. We no longer have our peer support specialists, it was heartbreaking. And I absolutely have loved the opportunity to work. And I personally, as a clinician, worked like hand in hand with, because we both had, each one had one for the adult and for the, long story short, because they cut the program, somehow they were able to keep me, like they kept me. And so now it's only 1 clinician, and I work with everybody. I work with still my youth and also with the adults. And watch that thing in the beginning, like of course, the majority of our adult resident clients have severe mental health. People, that are no longer, there's no place for them to go. People you see out on the streets. So I love the work that I do. I see it every day. I work with it, working with so much unhoused, whether it's youth, and shocking stories to find out that some youth have been around since they were like 15, and they're 18, and they've been in the streets for that long as well. So anyway, so we provide free services. I do free counseling, and so it's, yes, that LGBT, but it's intersex, allies. We have a lot of cisgender people that come in. We also have unhoused shelter. So I work there as well. I'm kind of mobile. I work a lot. So we have a shelter. It's a 14-bed. I don't know if people know this. I've only been working there for a year, and I came here from San Diego, and I'm learning the Sacramento. Okay, and I'm learning all the different resources and agencies as well. But so we have a shelter, and it's 14 beds, and I go, so Tuesday, Thursday, I'm at the community center, I work upstairs and downstairs and with the youth. And then, I also, Monday, Tuesday, Wednesdays, I go to the shelter and I work with, and everybody, most of the people, I work with people that come in from the community. We have on our website, we have a mental health request form. So I work with a spectrum or a variety of people with different types of mental health. I have worked with unhoused, severe mental health, and people in the community with, all kinds of, LGBTQ plus issues, or, everything, depression, anxiety, everything, almost anything you can read in the DSM-5. Right, so, in saying that, we also have another house. I don't know if this is general knowledge. I think it kind of is. So it's called the TOP program, Transitional Living Program. It's in, I can't just remember what it is. We have one. It's 6 beds, and I also work there. I drive out there, so I'm kind of mobile and pretty mobile therapist. So our program. We did use our peer specialist, but we have like a housing navigator. We help people get into housing. Like when you're on the streets, right? The goal is to get people housed, and mental health and everything that goes with it. So I want to go back a little bit to with the youth. So we have 2 respites for honestly, with the older people, there's not as much services. When you go upstairs, and by the way, you can call and go on a tour if you want to go on a tour for your agency. So upstairs, the youth they can get free counseling. We have advocates now. Our peer specialists are gone, but we have housing advocates. They help and they can wash their clothes. They even have food for pets. A lot of people have pets because you're used to sleeping on the street. It feels safe to have their pet with them, right? So they can wash their clothes. They can take showers. I don't know because downstairs that's not the case. So there's a lot of resources. We have computers. We can help them like print out or make resumes. So we do a lot of housing things. We have the housing advocate that we bring in, the navigator that we bring in. I'm probably forgetting some things, but it's all those things that people need to get out of the streets and get out of that cycle. There's a lot of shelters in Sacramento, and what I see is a lot of the youth, they call it shelter hopping, and the adults, right? Because the youth programs are only like, okay, you can go here for 9 days. And they finish their 9 days, they go to the Grove, and then they go to this one, and they go to that one, and they go back and forth, and then they'll come back to us, right? So a lot of the resources, and I hope I'm probably leaving some things out, because, and plus, we put on Pride, right? Pride's coming up real soon. Yeah, Pride. I'm at the Q spot. I'm with the TAG group, so you'll see me if you come to Pride. I'm in the Q spot. I just made a year this year. This week, I'm going to be there a whole year. So, yeah, thank you so much. And I'm kind of glad that they did the little bio, because as being a person of color, Mexican, we have lived experiences just by being a person of color. They mentioned I was a Mexican migrant worker. I started working in the fields when I walked. So I come from a long history. I was in the fields when the Chavez strikes were going on, and I lived in the city, in the inner city, and I worked with inner city youth and everything. So yes, and just kind of like my father had schizophrenia. So everything I seen today was like, oh my God, that was crazy, because my dad had to have alcohol and electric and all that stuff. Anyway, I want to get into this sidetrack. That's our organization. I'm sure I left some things out. It's a great place. We have an amazing staff, diverse staff, and I think that's okay. So I provide assistance for the youth and everybody, So I'm a licensed clinician. I'm a bilingual therapist. When I got there, everywhere I've ever learned, I said, hey, I've always worked, I've done Medi-Cal, I'll do everything. I said, you know what, because I was a TAE clinician, I said, hey, can I take on the Spanish speaking? And absolutely, so we also provide services for the Spanish speaking people. And also we have a closet, when people come in, not for the adults, but for the youth, we have a clothing closet, so, some people don't have clothes when they come in. Sometimes they don't even have shoes, right? So it's awesome, they can take showers, wash their clothes, they can eat, they can rest, they can watch TV, they can play video games. So anyway, I think I got it all.
Okay, so our next question is, what unique perspectives do peer support specialists bring to behavioral health care that traditional clinical roles might overlook, especially in culturally diverse communities? And anyone can start the question.
Sure. All right, so I'm gonna build some context to what and then I'll answer the question, otherwise it will be hard to explain it. So the community, like I said, that we serve, lots of ethnicities, lots of languages, lots of traumas, most countries and most of us. But outside of the US, so it's a very traditional community, right? And there's good and bad, and I'm originally from Afghanistan, and I came here as a kid. And so I've been raised here, but no matter what happens, your heart is connected to where you're from. And you slowly realize that as you grow older and you see hard times and you connect, and then your traumas that you've seen also align with that. And then you realize who you are or part of you. And so being raised here as an Afghan woman in a huge family of 10, being a middle child, you're always ignored. And so you kind of find your own place in whatever way you can find. And part of being, so you're in a society here in the US that's very individualistic, but then your beliefs and where you're from is very traditional. So many times it's hard to bring that together. And then as a human, as a female, you find where do you belong in all of this? Because most of the time up to now, and I'm 45 years old right now, it's very hard to know where, but eventually you find your little space. And so our community is very traditional, so there's good and bad in that. I'll go with the bad first. The bad is that, we are from a community that has a hard time going outside of our cultures. And when I say cultures, my God, we have so many, right? Most in the United States, or the way our communities are portrayed is, we are all Arabs, we're all Muslim, and we're all, and a word that I'm not gonna say, but we're not, right? We're from a lot of different cultures, we speak a lot of different languages, and we've had a lot of trauma and a lot of experiences, and at the same time, we have communities that are very poor, like the new refugees that are here now, and we have very affluent community, like the doctors and all the people in Silicon Valley and so forth. But the traditional aspect sticks, and that is a problem. It works back home because everywhere you look, you have family and support. And part of peer support is support. It's having someone to at least vent to, talk to, and it is acceptable. And you don't have to go too far because you have your 30 cousins and 30 family members right, 5 minutes away. Here, when you come here, it's a very different life. And so you're used to that, but it's hard to say, hey, I need to talk to someone that's outside of my family, mostly because of shame. There's a lot of problems reaching out outside of your family here because, what is that Afghan going to think? What is that Arab going to think? How am I going to be seen in the community if my daughter has a mental health issue? She won't get marriage proposals. Or my son has substance abuse issues. well, they're gonna think we're a family that just doesn't care. And so lots and lots of shame involved in that, because majority of our community believes in education and having a very close-knit family. And the reality is majority of our community has so much trauma and so many broken families that they end up doing what's best here in the United States, which is start to isolate and be by themselves. And that is where they keep on breaking up, and a lot of trauma and a lot of pain. So that's the bad part. The great part that I've seen, and I think it is a huge value, and especially if you know how to use it, the support system is there in the community. There's a huge Muslim community in Sacramento. And then within your family, the values are there to be able to talk. But of course, this works when you have basic issues, basic family problems. When it comes to having mental health problems, then you really need to reach out for specialists, because your community and your family, the love that's there is supportive, but they are not specialists. The religious leaders, which the community relies on heavily, is important, but for that spiritual connection, but they are not trained as mental health specialists. And so, we are trying to move towards supporting that and having learn about some of the specifics of how to treat those who have mental health issues. So good and bad in the community. Of course, being in a new country, you start a whole new life. It's very hard to navigate the system. Most of the time, our community comes into this country with a very different perspective. And then some learn it, that it's a total opposite. And some it takes a long time. I've learned in my 40s that if you can take that traditional model and the individualistic model and use it to your benefit, you have an excellent life here, because you've taught the traditional model of family, love, care, all of that, which is also in the United States, but it's kind of been watered down because of the way the system is. I mean, if you look at those in the 50s, 60s, even now, there's a lot of traditional values that connect and align with our culture, and it's beautiful. But then if you look at the opportunities here, if you can use both, and how you're gonna be very successful. But for our community, it takes a long time to connect, because the system there is so different. I mean, for example, right now we have a lot of refugees who are having issues with, schools are calling us about their children, how they can't focus in school, how they are sometimes marks on their body, so the concept of, in the US, you have the right to have children, but the government has the authority over those children. In our cultures, you have full authority. The government does not have that authority that the US does over your children. Again, there's good and bad in both models. So they have a hard time understanding, or the idea that a parent, a wife, and a husband will be treated 50-50 here in regards to taking care of your children and in terms of neglecting them. Back home, it's about, I'm the woman, I'm gonna take care of this, I'm gonna have my education. Very highly educated women in our country, but the core of it is you should be taking care of the family and your husband. And when they come here, they do both. The problem is this doesn't work for our communities, because who's taking care of the children if the mother and the father's outside making a lot of money? And again, there's good and bad in that, right? I've been raised here. I worked since I was 17 years old. My staff laugh at me because I don't know how to cook anything, but I see the value in being, having those traditional things at home, but also having the education and the independence that I have from being raised here. Wonderful values. And so the other thing I already captured, but I want to just talk a little more about, is not understanding trauma. So of course, there's a lot of support and a lot of, respect, for those who are educated in our community. So if you look at doctors, they will, or someone who has issues with regards to physical health, they will look at that, they'll understand it, they'll have sympathy, they'll have empathy for someone who's going through those. But of course, when it comes to mental health issues, as we all know, there's a label for it, and they don't they're not able to understand that. But here's the thing, all of them had so much trauma. Like look at Afghans, look at the Arabs, look at what's happening in Palestine right now. Those people that are being in a genocide and are being traumatized, wherever they go, they're gonna bring that trauma and that pain with them. The sad part is they don't know what's going on inside. They're dying slowly, and that has happened. Since I was a kid, I've seen that in my family where the trauma has broken up my family so much, whether it was siblings who tried to commit suicide or my uncle who had substance abuse and did kill himself, and I found him at 5 years old. All of these things, majority of our community think that these are hardships, these are difficulties, and because they have such great traditional values, they connect, they keep, they love, they take care of each other. But what's happening the whole time is they don't realize the trauma is never going to go away until you access services. On someone who's a specialist, whether it's a peer or a clinical, you need to get support. Now comes the issue of accessing services. In the mental health field, we already know there's a lack of specialists, therapists, and so forth. But now look at our community with all the languages and cultures. Being Arab is very different from being Afghan, from being Pakistani, from being Indian. You need those people to be in the workforce, which is why we trained over 100 community members who are from all these ethnicities to become peer support specialists. Most are volunteers because we can't afford to hire them. But in order to bring services that are culturally common to your community, you gotta change the workforce, which is an advice that came from California Department of Public Health Office of Health Equity when it came to evaluation and the funding we have for our program. And so in terms of trauma, trying to help them understand what that is, what it does, and the fact that it never will go away. We've tried so hard, and like I said at the beginning, now we're seeing the fruits of our labor and seeing people come in and grows of numbers trying to access services. Our Shifa for today, which is our peer support program, Shifa means healing in Arabic, is the program we've developed since 2016 at the current position I have. But like I said, I've been in mental health and peer support work since 2004, specifically peer support in 2009 when I got to connect and see Sally Zinman, which we all know and love and admire, and just the amazing work she did. And that's where I got to actually, I think it's the first time I was able to connect about, okay, wow, this program, peer support works for people that have been traumatized. Before that, I was at CIBHS before that, but of course they're more in training and so forth, and my position was in adult services department. So I got to just do the more administrative, programmatic stuff. But when I got to the network, that's where I really connected and found that, wow, I've been living through this. My family has been living through this. And then when I got to Mass SSF, my current position, this was a solution I suggested when the funding and opportunity came that, hey, let's try this. Let's see, maybe this peer support works. And like I said earlier, we are now part of a program that's saving California millions of dollars. And so Shifa for today has been something we've developed, and it's focused on prevention, early intervention. All our staff and peer support specialists are from the community. Our office is located purposefully away from mosques and community centers for the reason of stigma. Even our counseling room is one where we try to get people to come from the back door instead of the administrative office, because just being around these things, people will not access services. I had people approach me from mosques saying, please have sessions on substance abuse. But the challenge was, how do you get people to come? Because if there's a mother in the room and another one knows that maybe the daughter or son has substance abuse, they're not going to come. So we have virtual ones. We mask their names. We cover their names. We had 3 sessions, and the lowest attendance was 60. The high was 100. And not only within US, but outside of US, we have people attend because there's so much need. And lastly, I think I've answered some parts of the question you asked, but I think in terms of uniqueness, I think peer support specialists really do a wonderful job, at least for our community, in terms of serving in that position where they could help the therapist understand the client with regards to their culture, their lived experience, language they can interpret. But even if for those who don't have serious diagnosable issues, they can, of course, ask them, which is majority of our clients. But we also, of course, we have a small clinical program that we're trying to develop because we have those who are really seriously diagnosed. But again, who do they go to? Because there's very, very few that can talk to them and understand. And now they are all part of our community, and we have to be able to serve them in a way where they feel comfortable enough, where they could be understood and have people that look like them, and then they'll open up and start talking, and that's when recovery starts. Thank you.
Thank you. Before I give it to the next speakers real quick, this is set to go until 2:30, and then we want to leave a little bit of time at the end for Q&A. So I love the beautiful conversations that were being had, and thank you so much for sharing all of your lived experience. I just want to make sure we hear some more from all of your guys' perspectives before the Q&A. But thank you so much.
In our world, peer support is really important because when we call a facility or a program and start looking for services, believe it or not, we are scanning the phone for articulations that make me say, is that a Black person or not? When we walk in the room, we're scanning the room to see if there's other Black people in the room who look like me, feel like me, talk like me, who kind of understand where I'm coming from. I get phone calls from people saying, oh, they're in X, Y, and Z treatment program. I said, well, they have therapists in the treatment programs. They said, yeah, but they don't have anybody Black. They want somebody Black. Peer support is about understanding. A peer supporter is a person who understands the lived experience of the person who's in front of them, who can then say in the language and intonations and in the religious, ambiance of that particular person, how they translate what is going to happen, what could happen, and what is available to them in the moment. And so we are always looking for us in the space. When we walk down the street and we see each other, we try to make eye contact, and what level of trauma based on whether or not that person is living with, based on whether or not they make eye contact and say, hey, how you doing? Or if they look at you, they go, and act like they don't see you. So in our world, in a world where racism, discrimination, prejudice, sexism, all of that blends together to then influence our ability and willingness and trust of the systems that we're going into. Peer support people help to move beyond that and can help explain, help people sort of think about what options they have available, how to get around the chaos or confusion or challenges or the paperwork that's in front of them that needs that they need to fill out in order to get the services. And then they can tell you which counselors are good and which counselors are not. They know, and they will definitely share that information. So in our world, that's kind of where peer support, peer care coordination lives for us.
Yeah, I agree and I think that's the big issue is that there's just not enough people of color that are peer support specialists, that are clinicians, that are, on and on, psychologists or whatever else, all the mental health treatment that needs to happen for people. And also, what I really noticed when we got, because I got hired before our peer support specialist, I loved it so much because they can, our upstairs is like kind of like a living room, they mingle and they just walk up to somebody. And the other part of it too is that everybody upstairs, I think everybody is a person of color as well. And so what does that mean? People feel included or queer, right? And people feel like it's inclusive. It's like It's not a space like where, I don't know, somebody just, look at me in my eyes, That's the one thing that you'll hear about people that are not in a house as well is that, they go to, when they're at the store and somebody says, oh, people won't even acknowledge me, like I'm invisible. And I think that's the unique thing that I've seen at the peer specialist, being out there and just say, hey, how are you doing today? And that will start the whole thing. And I always tell people, it's like, okay, if they come to me first, I'm the first responder. If they're coming to you, you're the first responder in the situation, right? And that's where we start. That's where the interventions start. So I think that's a huge part of it. So definitely being in an environment that's culturally sensitive, that when people come in off the street and they just have some interactions because they're a person of color or because they're trans or all this stuff like that. And, so many are, like a black trans or a Mexican trans. They're targets right now in this political climate. It's scary. They're scared to get on the bus to come see me. They're scared walking down the street that somebody's going to attack them. That's real. That's just really. So coming into this inclusive environment, I don't think this is the first job I've ever worked in. I've worked in I've been doing therapy for a lot of years, and I've worked in nonprofits. Ours is a nonprofit, and I've worked in private practice, but I've never worked in a place where I felt so included, seen and heard. So I think that's a huge part of it.
Okay, so for our next question, in what ways can peer support specialists bridge gaps in trust between historically marginalized communities and traditional behavioral health services?
So for our program, the way we bridge the gap in trust is when we do our intake, we have the client select who they want to talk to. Which is why we've trained so many PSs, and we'll continue training as many as possible. And although I can't hire them all, it's just having, I don't know, for lack of a better word, a menu of different people to choose from, right? And keep in mind, one culture will say, many times we hear them, I don't want to talk to someone from mine because it's gonna get out in the community. I remember one call I received that was years ago, by a senior who was being abused a lot in his family. And at the end he asked me, he's like, what's your name again? I was like, oh, this is Nicole Shani. So he's like, well, I actually know your father for the last 30 years. So I would really appreciate if you can, keep this to yourself. And actually from here on, if I can talk to someone who is not from that culture. And so many people are afraid. So we got but we build the bridge and we connect create trust by having the client choose who they want to talk to, number one, whether it's ethnicity, gender, lived experience. So that's one way. Second way is, like I said, our office and where it's located and how we bring in clients. Third is that I've actually trained my staff, or informed them rather, to make sure they purposefully talk about the rules and regulations in the United States and how things are done with regards to documentation, files, HIPAA, and all that. Because many of the community we serve are from countries that maybe, law and order is not so strong. It's more about who you know and how much money and connections and a lot of corruption. Not to say there isn't that in the United States, but certainly it's in control. And it's, so we purposefully talk about rules and regulations and empower them to know that, hey, you can actually shut us down if we don't follow these rules. This is what we do. That really helps them a lot to understand. And then, so that's another one. And of course, in terms of other trust factors would be language. I mean, in mental health research, it shows that when you talk to someone in their language, not only are the chances of mental health improving is high, but Also, it makes that connection, comfort, culture. While we have, like I said, every ethnicity, including the LGBT community and the Muslim community, we are Muslims. Our values are aligned regardless of where we're from. And on top of that, we actually developed a curriculum. Once community members are trained as peer support specialists, to go through a training where they understand all the cultures and trauma-informed care. And in there, the very first module that they learn about is how the values of peer support and Islam are aligned and the same. And so we train them to see how it's connected. And then again, we go into the other aspects of understanding, how to work with the LGBT community, trauma-informed care, and many other aspects, different cultures. So I'll end with saying this: if you have a person walk into our office that maybe is Pakistani, and they say, hey, I don't want to see a Pakistani person because of the stigma of the information going around, they can choose an Afghan, an Arab, whoever. But that peer support specialist trained needs to understand their culture. And so we train them and trying to make sure they understand that before they can access services. And that is if they speak English. If they don't, then of course we stick to the ones that have the PS and that speak their languages. Thank you.
Thank you.
I've had so many different experiences with this. One of the things that is troubling is when is our philosophy about who the therapist is or the clinician is and what is the relationship with the client. It's almost as if it's this singular kind of portal, that what's important is that they trust me and we work on issues together and, I maintain their confidentiality. This is where they get the answers to what, issues that are going on, and they can talk about trauma and all of these different things. Our philosophy about that is a little different because the lives of the folks that we see are so complicated that if you're doing an intervention that only works for the individual, that is as far as it gets. And once they leave the office and they are back in a community collective that's happening, the community collective is stronger than what you're doing in there. Hence why you find so many people who drop out. You find people who end up missing appointments, coming late, because you are not engaged in the broader conversation of what's happening in their lives. If they go to counseling, if anybody knows that they're going to counseling, let's start there. So that's one problem. Nobody knows that they're going to counseling. They go to counseling and then they can't talk about what you talked about because they don't want anybody to know. If they do talk about it, it is now part of the community conversation. And they are comparing you to the last therapist that they had, or the other therapist that they saw, or the counselor down the street, or the pastor that they talked to, or, Medea who sits on the porch and gives everybody, advice about what's happening. What you are doing individually is being eroded by a community experience. Whatever you do has to be able to address what's going on in the broader community. And the community really needs to be a part of the intervention. And that's the place where we've failed. We have allowed this system of individuality to overrun the communal relationships and responsibility that we have to one another. And that sense of the we being how we are healed as opposed to the me that is capable of healing. And so the moment I run into a challenge, I'm by myself out there. But in reality, if I am in that communal system, there are people who are available to help me. The peer support navigators, right? Who look like the person, who speaks like the person, who is engaged in the community, knows the other doors to open. that will then expand the impact of what you're doing in the individual session. And if you don't have that, I'm gonna almost say you're wasting your time. You know, it's gonna take a year. You know how long it takes to make change, right? Individual change. But let your sister, let the sister know, let the auntie know, let the teacher at the school know what's going on, and then suddenly you have a chain effect. You know, a chain effect of what you're doing in counseling that shows up in school, that shows up in church, that shows up in the household, and everybody is being transformed by it.
Thank you. Yeah, I think that that allowing that safe place to be able to come and talk about all the things that you need to talk about that aren't talked about in other places. You know, you got something just happened to you, a racial incident happened, and that's what I think for a lot of people of color don't know that they haven't had the experience. You're right. You know, like, oh, well, that I had it because I hear that so much. Like, oh yeah, I talked to them, they weren't listening, or they didn't care. But, you know, they really got that. That's kind of what shut them away, or they feel like, oh, you know what, these people just aren't going to understand me. They don't want to hear what I have to say. But having those places to be able to express that, you know, all their feelings and emotions about all the things that are happening is what needs to happen. And a lot of people don't feel comfortable or feel like their needs are being heard and met and seen and all those things. So, and the other part of it too is I think having, you know, again, you know, training staff to, you know, like cultural diversity training and humility and all of that. You know, this current political climate has weaponized the word diversity. What do you mean? You know, we just watched the whole morning thing because that was about so many things, right? Because, you know, people are suffering from trauma and addiction and self-medicating addiction for, you know, a generational trauma for hundreds and hundreds of years. And those things aren't being addressed. You know, after we go through some kind of huge thing that happened, you know, after riots and stuff, the reason they're happening is because nobody's dealing with it. Nobody's having those talks. And at least we should be able to offer that and have a safe place in therapy or peer support specialist. Because I love working with peer support specialists because it's like, there's so much work to do. Right? There's like, we all need to work together as a team, right? Just like this person, that's the first thing I do is I'll come out and say, oh, can you help me with this? Can you help me with this? You know, right? So I think those are the things how we can kind of bridge the gaps is just to, you know, we have to educate people, right, about a lot of things.
Thank you so much to our amazing panelists. We have a little bit of time for Q&A. We have about 8 minutes. If anyone has any questions for any of the panelists, okay, you were the first hand that I saw. Oh no, there's someone coming with the mic.
My question is for Sean. I'm so sorry.
It's okay. Gulshan.
Sean, with the political climate that's going on today, how has masks been affected, or have you seen masks influenced by our political climate or anything like that, or anything that's going on in Palestine with the refugees coming over here?
All right. So the question is, how have we been affected?
How have we been affected given the global climate with Palestine and so forth? Okay. Thank you for your question. For us, of course, as a community, it's very, very painful. it is something that, as I was going to school here in the US and I learned about the Holocaust, I thought that's probably the worst thing that I've ever seen. And of course, there's other historical traumas, how slaves were treated in the United States, African American community, all these things. And then seeing this one, I'm not saying that it's worse, but the wave does not stop. And no one cares enough to stop it. And now that no one cares, it is something, it's almost as unbelievable as the United States being such a superpower, almost slowly going down right in front of our eyes. It is that disbelief, and I have full conviction and being raised in the United States that it is a country where you can do whatever you put your heart out to do. I've seen it, and I'm living through it, and so the pain is, I don't know how to even describe it, to the point where as a human being you feel ashamed that you can't do anything, but at the same time for your mental health wellness you have to put it to the side, but the whole time you feel very ashamed that something like this is happening. So there's a lot of pain and trauma in our community. And although everyone is trying to help, it's just nothing is working right now because it's much bigger than us. That's one thing. Number two, so that affects your confidence, that affects who you are, that affects, when you look at the countries, I think it's 190 or so in the world, and about 50 countries, I think, are Muslim, or 57. And the first time that I heard a little bit of hope was just this in the past few weeks, where an Arab sister made a statement in the news saying, for the first time, there is a brother that is protecting us in a country of 57 sisters. And that relates to what happened in Pakistan and India, where Pakistan was able to support and protect people from getting killed by a country that's 8 times bigger than them, and that is trying to make that into a Palestine. So it's very painful because watching that Arab sister talk about that, it just brings everything back. So it's very, very painful. Funding-wise, politically, we have not been affected, thank God, because we are part of groups that, like I said earlier, we're part of many groups that are underserved. Our brothers and sisters in the African American community, Native American, Latinx, LGBT community are so supportive because we're the same. And we are so similar than different. And so because of those things, and the people who are at different government entities are protecting us in terms of not having our funding affected, not yet at least, and hopefully. So financially we have not been affected, but painful and trauma-wise, of course, it's just getting worse and worse.
Thank you. Who would like to? Oh, right here. Yeah.
Hi, my name is Shane, and I'm a U.S. Coast Guard veteran. My question is, in the VA, we have peer support specialists, or they call it peer support. With that experience, that's the only one who can come and be a veteran. Very protected position. How in the community, since we have bases, is there ever been any connection with organizations there that have gone to the VA and see what they do, or at all? That's my question. Daniel.
Who would like to answer this question about crossovers between the VA and your organization?
So in our world, we work with the VA for folks who are homeless in particular, and trying to acquire some level of support for them in that space. That's helpful. But You know, I think for us, it is a matter of being able to have access to people within the VA system, and the VA is a system. Yeah, it's huge, it's great, but when we are trying to get people who don't comply with the rules and, you know, follow through with the paperwork and make the appointments on time, then that's where our challenge comes in. But we have lots of veterans who come through the facility and have had, you know, a variety of different experiences. But in terms of establishing a formal connection with the VA, not yet.
Thank you so much. So that's all the time that we have for the panel and the QA. And I just want to give another special thanks to all three of our panelists. Thank you so much for taking the time. Stephanie's going to come back and make an announcement, but we really appreciate all the great work that each of your organizations do. And thank you so much for taking time out of your busy schedules to come and talk to us today. Thank you.
How's everybody doing? Are you still kind of almost awake? Okay, so just a couple things. I, again, really appreciate our panel. I think it really ties into a lot of what we've talked about so far throughout the day. I see a lot of dots connecting for folks. And some of the kind of themes I heard from you all were really around finding a place of understanding, right? Going somewhere where people understand you, your perspective, your background, having a place to belong, right? That's so important for all of us. Diversity at all levels, right? And we know often in our system, our peers and sometimes our paraprofessionals, we see a lot of diversity within those professions, and we know that there are other external barriers, right, that do impact diversity at different levels within our system. And the other comment I was hearing a lot was about a safe space. And a new term I've been hearing about is a brave space. So how can we be brave in those spaces, right? Even if it's a safe space, right? How are we building connections? How are we feeling belonging? How are we feeling understood? And then can we step into a place of bravery to be able to disclose what's difficult, to, you know, overcome the fears that our panelists were talking about. And so just kind of, and I think that goes so much back to what we've been talking about in the morning, right? Is relationships, friendships, connection. Like, I feel like that's really been a theme of today. Even though that wasn't our official theme, I think that's what has come out of our discussion. And so thinking about, like, how can you bring that message back into your organization about not just like, okay, are we, you know, connecting the dots and we're doing all the services, but are we doing it in a way that fosters belonging, understanding, that people feel that that is a place that they can be brave, right? And they can feel safe, and they can engage, and they can take risks, and they can try new things carefully. We need to have those opportunities. So I just want to really thank our panel. I think that this was stepping into a brave space, right? Talking about challenges that our communities that we belong to face. And it is brave to get up here and talk about it, because we know people have different perspectives, different experiences. We all watch the news, you're on social media, there's a lot that's going on. So I just want to thank you for being vulnerable and being in this space and really helping inform us as well. So we are going to take a brief break. It says 2:45, but I took 2 of your minutes, so you get 2:47. Photos, no one's been taking them. If you can take photos, that'd be great. We have our little QR codes around the room. There are still a few outdoor activities. I know it's warming up, but come back at 2:47 if you're going to jump into our last speaker.
Oh no, it's okay. Thank you. Right. Yeah, no, it was great. I really liked the panel. I'm glad it worked out. And you don't like it. I honestly I don't want to.
Yeah, I think she's gonna bring that to your phone. Oh, yes. I wanted to tell you I'm a newcomer. My name is Mary. Asia is fantastic. And Lydia is sitting next to me. And she's being trained right now. And we're friends from now. Yes, I came last year. I was like, I'm not missing. You should have seen how many emails. Do you have the date yet? Do you have the date yet? No, yeah, please give her kudos. Oh, okay, great. Thank you so much. Okay. You bet.
No. Oh, well, I have adjusted some of them since we were sitting back there, but it's okay. Oh, put it on. Okay. No. Let's just. No. Oh, no. But there's probably like the notes might be like so long. That's why I have it like this, because then I can go through and I can read everything, so I can make sure I didn't get it. So it's okay to have two. No. Can it go right there? That way, because I tried to sit in both, but I don't want to bump this. Oh, there's no cook. But I'm gonna get you right. You said what? You sure? Okay. No. Yeah, it's okay. Okay. I need. I'll be right back. And I'm gonna run the rest of it. Trust me, I'm like, I'll figure it out. Don't worry about it. You're so silly. Thank you so much. Okay, so this will put me on this one, right? Okay, no worries. I know I'm standing between them and going home. I will also. Actually, I like this one. I hear you.
Okay.
There you are.
See, we're back. Okay. Okay. We're still going. We're
Fine.
still going. It didn't stop it. I was like, am I gonna restart it? Okay.
Welcome back, everybody. Welcome back. If you can hear me, clap once. If you can hear me, clap twice. If you can hear me, clap three times. Okay, I think we're back to one more time. Ready? If you can hear me, clap once. If you can hear me, clap twice. If you can hear me, clap three times. All right, I think we got the attention of the folks outside. We have our final speaker. Following our final speaker, we'll do our raffle, so you definitely don't want to leave. Our final speaker, those of you may know, but is our own local celebrity. Yes. And if you don't know her, you're about to know her. So we are very blessed to have Ebony Chambers and LaClinton join us. She is a seasoned leader with over 20 years of experience in social justice, equity, child welfare, mental health, and diversity. She offers consultation on strategic change, equity initiatives, and leadership development, drawing on personal and professional experience. A national speaker and facilitator, Ebony advocates for mental health access and stigma reduction in underserved communities. She has trained schools, agencies, and universities through nonprofit work, consulting, and through UC Davis, focusing on culturally responsive practices and inclusive leadership. She's also worked with the National Council for Behavioral Health to address LGBTQ health disparities. Ebony's honors include the Sacramento Sporty Under 40, Biz Women Headliner, Top 25 Black Changemakers, and Pride Grand Marshal. She serves on the MHSA Steering Committee and is board president of the okay, that's over. She serves on the MHSA Steering Committee and as board member of the Black Women United, championing education, empowerment, and inclusion of Black women and girls while ensuring community voice and drive systems change. I just have to say, I've known Ebony now probably for at least 15 years. Incredible, amazing, kind, humble. I'll stop now, but please help me welcome Ebony Chambers.
All right, let me see if I can fix this. Good afternoon, everybody. I'm the one holding you between the raffle and going home. So we're gonna stay all night. It's time to party. I won't keep you late, I promise. But I do want to do a quick temperature check because I've been kind of quiet over the last panel. So we're gonna wake up a little bit to close this G thing out. Am I right? Yes, all right. So if you like what you hear, we get to snap. Everybody practice snapping. Sometimes we do it when we're hearing good poetry that seem really like woke and down. Who does that? All right, so we snap. Or if we hear names we know, or we love things we're hearing, we clap. So we're gonna practice clapping. All right, that was a little weak. Let's try it again. Clapping. All right, that's perfect. All right. And then if we hear things like really meaningful to us, we can go, oh, like we saw a new kitty who likes cats. Oh, thank you. All right. Thank you for practicing with me. We're gonna go ahead and get started. I am grateful to be here. I feel like I'm at home. For those that I don't know in this space, I've worked a lot in Sacramento County, but over the last few years, I've expanded that work across the state of California and across the United States. And so being here where I grew up, where I cut my teeth in mental and behavioral health and in child welfare systems and in juvenile justice systems, feels like a coming home because I'm back to my roots, if that makes sense. And so I actually got my start working first in residential care And I remember seeing kids in holds. And as a system administrator, I was mortified by what was happening. And I realized I was also complicit to what was happening. And this organization, shout out to Stanford Sierra Youth and Families. I know there's lots of folks here. They came into the organization, they came into my residential treatment, and they started getting kids home and started getting kids better. And I was like, that's where I want to go. And after a few child and family team meetings and all of these practices just felt so restorative was when I was like, and that's it, I quit. And I quit that day. Like I gave it 2 weeks notice, but I was just like, I got to go to Stanford. And I hadn't even applied with them yet. But I applied, and thankfully I got the job. And I served there for almost 20 years, ending as the Chief Equity and Partnership Officer. And so I was really excited about being there. But then at the same time, I got my own lived experience. I realized I was a person also living with anxiety. And I had also just adopted my oldest daughter, who's now 32, and she was living with depression. And as much as I knew about all the system supports that were out there and how much I had done as a professional, nothing compared to the bullshit I had to navigate as a parent and as an individual myself, trying to navigate and get my own mental health services. And I thought, we have to do something different. I started with 3 youth advocates and parent partners. When I say 3, that meant a 3 combined. So 1 parent partner and 2 youth advocates, almost 15 years ago. And now there are over 45 parent partners, family partners, and youth advocates serving out of that organization across Northern California. And that's something that I'm extremely proud of. So I'm super appreciative of that. But I know that this is not just about me. It's about this collective power in this room. And that's what this movement is all about. So if we can, before we get started, because we've heard so much today and we've been a part of so much, just to collectively take a break and inhale and breathe. I say, let's inhale some power and exhale system bullshit. All right. Let's inhale our why and exhale the heavy weight that sometimes we carry as individuals, as family members, as community members, as loved ones who have experienced harm. It's so important for us to remember to breathe. I'm going ahead of myself. Let me find my space. I put notes, y'all, because I will have y'all here till 7, so I really will get y'all out on time, I promise. All right, so it's important when we talk about, and my theme was roots and rising, because I was like, let's go back to the roots. And I really appreciate Vesper this morning bringing us back to that history, right? Because there is so much liberation and power that's existed before us. And then there is the power that's also in this room. Peer support did not begin in a policy manual, right? It wasn't handed down by a state agency. We grew it ourselves, our community, our ancestors, those that have walked before us. So it was really born from the ground up. And there was people who were told time and time again, and who are still told, that their voices don't matter. Folks continuing to navigate systems that never expected them to survive, let alone come back and help others to thrive, which is what we're all doing today. We know that we've been there, we see others, and we believe in others, and we say, let's do this and let's walk together. And that's powerful. The brilliance that I find in peer support is that it doesn't exist in perfect conditions. It doesn't rely on perfect conditions to thrive. Our peer support thrives in real conditions, right? It's because we've lived them, and we know what it's like to sit in a meeting and feel invisible. I know what it's like as a mother and as an individual navigating services to be in wait rooms and fill out the paperwork and for them to tell me that the services are available and then turn around and find out that they're not, or they weren't exactly as they described it, or some other crock of shit that continues to disappoint me and my community members and those that look like me. I've cried in bathrooms and I've screamed about advocacy until my voice has been hoarse. And I know that that's not me and me alone. I know that that resonates with many of us here. The thing is our peer support is not just a service. It really is a movement. It's a call to build systems that really reflect community, not just control it or control us. To center people and not paperwork, and to return to the original intent, which is connection and trust and healing. Because in a time when lived experience starting to feel like it's being co-opted, and so many other areas of our lives start to feel controlled, we are the people that have to preserve the essence and the intention of peer support. That is our task. I'm a numbers person. That can be quite boring, I know. But I love being able to look at numbers and be able to better understand community. And at first I thought I should bring all the statistics about how when peers are in the room, we see an increase of what has been shown as a 30% increase in engagement. But I would honestly say that it's always quite more than 30% in engagement when peers come into the space. Across Sacramento, there are over 300 peer staff working in Sacramento doing very meaningful hard work. So thank you, and give yourselves a round of applause for all that you do. But thousands of lives become transformed when you all step into the room, and it's important for us to recognize that. So I mentioned my own lived experience, but just last week I was in a meeting. Sorry, getting some water. With my sister-in-law and my niece. And my sister-in-law and my niece were super frustrated. She has a recent diagnosis that's pretty scary for her and our family. And we're trying to figure it out and navigate it. And I'm trying to help my sister-in-law and I'm trying to help my niece. And they started with services and they were frustrated. And they had good reason to be, because they had asked for things and they weren't getting what they needed. And so I said, let's ask for meetings. Let's ask for a meeting. Let's bring people together. And we got there, or I got there virtually, and there was a lot of professionals in the room. But what significantly shifted that space were the peer advocates. The family was frustrated, we were frustrated, and the minute the peers in that room spoke, the energy shifted. They started talking about their strengths, and they brought it back so that my family felt seen, and it was powerful. There's two people here that I just want to acknowledge, and that's Kira and Marlene, if they could stand. They were there in that meeting. And I think that is, again, becomes the essence of that work. So thank you, Kira, and it looks like Marlene's gone. But that is the essence of peer work. I was like, this is that powerful moment. This is the change that we need to see. And I could not have asked for a better group of advocates in the space, but I know that that's reflective of all of the folks that are here in this room. Yes, go Heartland, go all of y'all. I also am reminded that peers are not just support, they are systems stabilizers, they are relational experts, and we are the protectors of dignity when systems have forgotten how to listen to us. Something else I learned was that we're not here to fit into a system. We're here to transform them. And that's all of our task. When we do this work every day, we get to change the emotional temperature of the entire system. And that's very powerful. All right. I mentioned that relational expert and protectors of dignity And it's because we do. We deserve to be seen, and we deserve to be able to heal on our own terms. And peers help to facilitate that process. All right. The work we do is also liberation work. I appreciated, again, Vesper this morning talking about the history, because all of that was shared, that rich history, we're all a part of that tapestry. And that is all liberation work. Your lived experience and our collective lived experience is knowledge. There is wisdom in our survival, and we get to share that wisdom with others. But I think it's also important to recognize that that wisdom is a threat to our systems, because our systems have been built on control. And that's why sometimes they try to over-professionalize the work that we do, but we're not going to let them. Some of the most powerful, transformative moments I've seen in behavioral health have come from peers. Not clinical interventions, and not a very, very nicely well-written treatment plan.
Come on.
It's come from all of us. Peers showing up with compassion, vulnerability, and presence. So I want us to take a pause and actually check in really quickly at our tables, because I believe that the collective power in this room also has something to share with maybe a neighbor who's gonna go to church and say, neighbor. That's my black church. That's my black church. It's like, touch a neighbor and agree. So we're gonna touch a neighbor and agree around who was there for you in your journey, who guided you. Maybe it was a stranger, a mentor, someone you're working with. Who showed up and stood beside you, and who was it that taught you what matters and that you matter? So take a moment, just real quick, to do a quick reflection, talk to a neighbor, and answer that question. We're gonna come back in like 1-2 minutes. can clap. But I'm gonna try something different. Yeah, no, we're not doing that. To the windows. Come on. Okay, we're back. We're back. We're back. We're not gonna keep singing that song, but I just wanted to make sure y'all were back. Okay. Well, I'd love to hear if there is one or two people that might be willing to share. Someone that was meaningful to them, someone that taught them something, someone that shared something with them.
I will share.
Oh, they're gonna bring you the mic.
Mine was like a collective of people, and I truly mean this. It was just Stanford as a whole, like working in FYP. First off, I didn't even know lived experience was a thing to work off of before I got this job. I was a youth advocate before this, but in the high schools, way different than this.
Right.
So just my team, like the days that I come into team meetings not feeling like myself, and my supervisor's like, come talk to me, like her reading me and knowing me, and I really feel like that support is really there, truly there. And like them telling us, like, you know, we have to prioritize ourselves. There's a work-life balance, and like making sure that we're good so that way we can serve our families. And then knowing that my families really love me, and hearing like the feedback come back, like, oh my gosh, Risha, that family yesterday in the CFT, they said this, and that, and the family really appreciated that you came with these resources and you advocated for them and said the things that they were afraid to say in those meetings. So like, really my team.
Awesome. How many other people, when you got the job, was like, I didn't know I could get paid for going through some crazy stuff? Like, what? This could be a career? No, we're gonna talk about pay in a minute because equity is the next thing we're talking about. But no, we definitely. Thank you for sharing that. Anyone else want to share? Over here. Over here. Sorry. Thank you.
So actually the person who taught me what matters is myself. I went through a lot of being told to shut up. Nobody cares about what you're struggling with. I was given I have a plethora of horrible diagnoses, one being schizoaffective. And so when you grow up with stuff like this, when your life completely falls apart and you have your support people, in my aspect, it was one of my therapists told me that, you know what, you're going to live in a group home, you're not going to be able to work full time, you're not going to have your own family. And I fell for that, I really honestly did. Until I got to the point where I was like, this is not my life, this is not what matters, this is not what I'm doing. And I pushed myself, and I created a aspect of my life where, you know what, this is what I know I'm highly adaptable, I know that I have something to give. And so trusting in myself and what I know and the experiences of everybody else that I helped with, that's really what got me here.
And that's powerful because you ended up being the person that you're the person that you needed, right? And that's beautiful. That's beautiful. Thank you. All right, we'll have one more.
Hey, you guys scared me if I get nervous when I get on mic. But so I can say myself, and then I have another person. So, you know, a lot of people went through Stanford Youth Solutions. So I'll say in 2017, they actually helped one of my sons with unification. So they had somebody talk to me, you know, leave with me. So I'm not gonna say their names, I don't think they're there no more, but I love them who came and worked with me and my son. And I actually just went through my younger son going through Stanford because I'm like, I don't trust really anybody else to talk to, but they actually were really good with helping reunification with my first son coming back home from San Diego. That was 2017, and then last year I actually went through them with my youngest. So they've always been there. So when y'all said that name, I'm like, you know, that's a good agency, and that's who really did help us. And other than that, me being a single mom, you know, the different things, just me myself having to deal with all the, you know, like as far as domestic violence or, you know, just my kids, everything, I just have to have my affirmations and learn to deal with it kind of on my own with somebody there to talk to me.
That's awesome. Thank you.
long as she was not paid by Stanford to share that information. Not the paid ass, y'all. No, but it speaks to the collective, again, the collective power that's in this space from those that have been there and showed up for us, and now we get to do the same for others. So it is really powerful. All right. So let's talk a little bit about equity. If you know me, you know this is the area that is my jam. And it's because as long as we're continuing in the way that we are, we won't see equity achieved. It requires us to do something different, and it can't be optional. It can't be an add-on. And we know with the current political landscape that it is targeting people that look like me and people that look like many of us in this room. Peer support actually doesn't exist without talking about equity. All of the liberation and fight and civil rights that came before us has been a part of the fight for equity in our supports and our services. So we oftentimes will see systems say, oh, we want peer voices, we want them at the table. But suddenly folks are a little too emotional and a little too angry or a little unprofessional when we start speaking up and advocating for ourselves. And that gets amplified when there are Black voices, Muslim voices, queer voices, trans voices, neurodivergent voices, and folks living with disabilities, right? And so it's important, even more so, to ensure that as peer advocates, when we think about centering this work, we center it around equity, but we also think about who are the folks that have been most historically marginalized, disenfranchised, and put at the margins of our systems, and make sure that their voices are at the center of this. If your peer support work is not centering equity, it's performative. Equity means asking your organization really hard questions around diagnosis. I heard someone ask this morning, what happens when your organization, what happens if you know that people are being overdiagnosed with conduct disorder? Or how do you even find that out? Ask your organization leadership. Say, what is the rate of Black and brown youth being diagnosed with conduct disorder? And how does that compare to their white counterparts? And if they can't answer you, they're probably lying. I say that because every organization tracks their diagnosis, and they track it by race. And if they're doing a really good job, they're also tracking it by LGBTQ orientation and gender expression as well, which means they have the numbers and they can look at those statistics and give you real answers. And once you find what those answers are, you go back and you say, now what are we doing about it? That's advocacy in action. And so we have a real opportunity to go back to our organizations and ask those hard questions. Equity is also naming microaggressions and bias and discrimination when we see it in the workplace, not just when it's happening to our clients, but when it's happening to our colleagues. And that happens in our meetings. I've been in too many where I've seen it. It happens in our supervision sometimes in one-on-one. And it's important for us to all be a part of voices that can really counter when that happens in the workplace. If you think your organization doesn't have any inequities, then you're not paying attention. Because every organization has it, because it's literally caked into all of our systems. It also means that we're also doing our own personal work. And that is more than just attending trainings every once in a while, or engaging in your cultural insight activity. Y'all know what I'm talking about, Stanford. Which are just one-off dialogues. It's work every day. It's examining where you hold amounts of privilege and recognizing what those identities are. I have them myself. I have a higher socioeconomic status.
I'm on planes practically every week, traveling to different places. I get to vacation nicely, and my home will be paid off in 4 years. That is privilege. That is privilege. But I'm also a Black woman. And I walk into the grocery store and they don't give a damn about everything I just shared with you. They still follow me. I was in Dick's Sporting Goods yesterday and I looked back and I said, she keep folding the shirts right next to me because she was following me. That's a reality too. I'm also a queer woman. And it's hidden because I like everything and everybody and I'm married to a man. But I still hear people say really heavy and hard things about the queer community thinking that I'm not. That's another identity that causes harm. All of you may hold identities that hold both privilege and that experience harm. And it's important for you to recognize when you hold those areas of privilege and you're in spaces where you can speak for those that do not, it is our intentional right to do so. That means doing it even when your voice shakes. That means doing it even when your stomach hurts a little bit or you start feeling a little hot. I don't know, maybe that's just me. That's how I respond when I'm getting a little nervous and I'm advocating. But it's necessary for change. There's been a lot of questions today around the political landscape and what do we do and what do we say? I will say one thing for sure is that our silence is violence. If we say nothing, nothing happens. If we do nothing, nothing happens. If we can't be in spaces and say free Palestine openly for everyone to hear, we're not supporting all of our community members. If we can't allow and say that trans rights are human rights, we're not supporting all. This is our task as advocates. Knowing what we've been through and knowing what we've had to navigate means that we have to recognize what other people are navigating, even if their identities do not look like our own. And sometimes that takes a lot of courage, but I believe that we can all do it. And under this landscape currently, we will make it through when we take steps like that. I do believe we cannot hold healing with also holding accountability and examining our systems of power. And right now, those power structures are chaotic, y'all. It's like you wake up every day. Is it just me? And go, what's gonna happen today? Oh, great, I'm scared. And we have reason to be, but I do think that with, again, this collective space and all of the 300 plus advocates just in this city of Sacramento means that we have an opportunity to speak up and have our voices heard. Pay came up as well today. I've been listening, trying to hear what folks have to say. You deserve to be paid not just a livable wage, but one where you can thrive. When we're thinking about what we do with that, there is options, and Vesper shared a few. There was folks along the side of the room, different organizations that will support member organizations. Many of your organizations are a part of state memberships, like the California Alliance. There is the Peer Partner, UC Davis Peer Partner Association, and many others that they're wanting to know, what do peers need and what's the call to action? So I ask, what is the Family Advocate Committee doing? And what are the youth advocate committees doing here in Sacramento where you're making demands around pay like this? It's time to mobilize. It's time to come together and say, this is no longer acceptable. Here's what we demand. We won't see change if we don't. And we should be getting paid more than In-N-Out Burger employees. I want to stop because I want to see if folks have any questions before we move into the next section. And I also do want to do a time check because I want to get y'all out on time. Any questions before I move on? All right. That means I've answered everything. We're good to go. All right. All right. So then we've got another reflection question for you. And I want you to ask yourself, there's a few here to start. Where in your work have you been invited to show up but not lead? There's a lot of tokenization in the lived experience worlds and the worlds that we live in where folks ask us to come into the room and then they give us our gift card and say thank you, and they never follow up with what we contributed, and we have no idea what changes we've made or in what impact we've made to the organization. So where have you been in spaces where you've been asked to show up but not lead? Where have you been holding space but folks aren't holding you? So take a moment to just hold space for yourself to think about those questions, and then turn to a neighbor, and touch and agree and share. Right. We're gonna come on back. Coming on back. Wrapping up our conversations. We'll try this one now. Sweet Caroline. All right, I know we're back now. All right. Anyone have one they want to share? Anybody want to have an experience that came up at their table that they feel comfortable sharing with the group? Anyone got one? Okay, we see right here in the front and center. Thank you.
I know for me as a woman of faith, in the community of faith that I've been in, I have often been invited to show up and speak in white evangelical spaces, but not allowed to lead or present myself as authentically in the wholeness of my faith evolution and what I contain in my lived experience as a woman and as a Latina woman and as a woman who has served globally with a whole lot more experience of people that are on payroll. So I have learned to uninvite myself cordially from those spaces because who I am and the wholeness of who I am deserves to be honored. In those same spaces, I have not been helped through grief, through trauma, through PTSD, and through re-entry after serving over 7 years abroad by those same organizations that would send me but not hold me when I came back and fell apart. So I deserve healing and freedom from that.
Absolutely.
And I get to, again, uninvite myself cordially, respectfully, from those places that could not pick me up when I was down.
That's right. That's powerful. Thank you for sharing that. And that's right? Like if we know that folks are not honoring our voices, are not bringing us in, we deserve to uninvite ourselves, right, from those spaces and say, hey, a good old color purple, until you do right by me, I am not going to continue to work with you. And so it's important for us to hold that line because we deserve to be held right. Anyone else? Thank you.
Hello, everybody. Thank you. I'm speaking here with Lori next to me. She's sharing her story. I'm sharing mine. There's many spaces where my identity has been tokenized, and I've been asked to show up to spaces to speak, to share my trauma, and to do the emotional labor that would inspire someone else. Oftentimes, there are people that don't look like me that want that inspiration from my stories. But I love the question of being who asked it. But it was around financial compensation for the work we do. And if there's anything that's true that I've noticed is that the people in this space deserve it so much because you're doing it because you love it. It's like, we know we're not here for the money. And at the same time, that doesn't mean you deserve less money, right? We deserve to be able to take our families on vacation, to be able to enjoy our weekends, to be able to rest and restore ourselves so that, like what we were talking about, like we're able to give from a full cup and not from an empty one. And the conversations do become performative where it's like we're being told how much they value us and how our lived experience is so important. And then the thing that is really important in our society is resources, right? And if you're not getting resources, you're being told how valuable you are. Something like what we said, it's not adding up. So I think the conversations are important, and as taboo as it is to talk about finances, I think we should be constantly fostering that conversation. So thank you.
Yeah. I appreciate you saying that because talking about finances shouldn't be taboo, right? Right? And when I always tell organizations when they say, "Oh, we can't afford to pay folks more," look at the pay scales. And always say wherever the highest money is going is what they prioritize. Yeah. And that goes for anything, right? When I was at Stanford, the same thing. There was a conversation around growing peers, and the question was, well, how will we do it? We want it, but how will we do it? And my response was, well, we're going to write it into every single thing we apply for. We will say that peers are non-negotiable. So every new program that gets started has to have peers in part of it because lived experience needs to be embedded and integrated in all we do, right? And so that's how we were able to grow the work. However, There has to be additional demands and advocacy at a state level, and that starts with all of us to say, we can do these things because we love it, but we don't deserve to get paid pennies on the dollar for it. That's unacceptable. I think Abby was gonna share something too.
All right. I'm Abby. I work for Stanford Charities and Families. I'm a FIG youth advocate. So at the same time, we're underpaid, but we're also overpaid, right, for doing this work because it's so rewarding. My suggestion is that, the people at the top, right, our managers and then above them who deal with the logistics would need to streamline the information to us so we understand why we're not being paid more. Because I've asked those tough questions in my console, so I understand, how the money is getting funneled down through the state for grants and stuff. And so I think the ask is how to be really strategic and implement a lot of thought and energy into talking to those leaders. And I think in any space, we don't need permission to be a leader. If you want to rewrite your job description, try it, do it. If you want to expand, if you want to feel empowered to go into a certain niche or a specific skill set, besides just being a peer support specialist, grow on that. And then I promise you, the money will come, just maybe not the way that you expect it. Because your cup cannot be full from a single job itself or from any one person. You gotta fill your own cup and you gotta figure out where to get it from.
Come on. Abby's about to come up here and take over, y'all. Abby, come get the push. Thank you for that. Absolutely. Everyone's journey looks different, right? And so we all have work to do when it comes to ensuring there's pay equity, and there's lots of pathways to get there, right? But understanding the landscape is one of them, right? I can demand more pay, but if the systems and structures aren't built to do it, that brings about another question. But the questions have to be asked. We have to ask, we have to dig deeper, and we have to make some demands and do some advocacy work around that. All right. Oh, one last one, and then we'll keep going. I want to make sure we have enough time.
The pay scale.
Pay scale.
Like, if the pay scale from 21 to 26, then why are they paying the lower amount? Are they saying that you need to be certified or you need to do this? But it says within a certain amount of days, so then you should get that higher pay scale if so why are they giving you the bottom money?
I can talk with you about that offline. However, what I'm hearing, Cal Voices, is there is some opportunity, and Sac County Behavioral Health, I know they're in the house too, there's some opportunity for us to have collective conversations about this, right? So that people do understand what pay scales mean, right? That's advocacy as well, is system transparency and understanding the whys behind that and it being explained at higher, right? So we're not confused about why things are happening the way they are. So it's a great question, and I think they deserve answers, and we deserve to have that kind of transparency. So thank you for that. I recognize this kind of conversations, they can be exhausting for all of us, right? And as we move through this journey of advocacy and peer support, it's not easy. It's not easy. And so I would be remiss to not talk about how we sustain ourselves in these types of journeys that we're all on together. And we don't talk about this enough, or maybe you do, but it doesn't feel like folks maybe truly care. Or someone thinks of self-care as just getting a massage or getting your nails done. And let's just be honest, that $22 an hour ain't gonna be able to afford a full set. I can't afford a full set off of that. And so we deserve, right? We deserve value. We deserve fair pay and protection and growth. But you also deserve rest. Rest is resistance. And if you're familiar with Tricia Hersey, she has an amazing book, and there's workbooks and affirmation cards that go along with it. But I'll leave it there to just say that it is our birthright and a revolutionary act to pace ourselves and sustain ourselves in this work. And that means taking breaks when we need to and not being martyrs. We won't sustain ourselves if we're constantly putting ourselves on the line, not taking days off, working when we're not supposed to, starting our day at 8 a.m. and ending it at 9 p.m. And they will replace your ass tomorrow if you fall over and wind up in the hospital. I promise you that. The families in our community will continue to thrive, and they'll thrive even more when we're doing really good care for ourselves. So it's important to be mindful of your wellness your rest, and your boundaries in this work. You all are asked to hold a lot. We all are. To absorb pain, to navigate crisis, and to stretch systems that were really never built for us. But all of us are doing this day to day with not just grace, but a hell of a lot of grit. So you have to remember, you're not martyrs, you're humans and you're leaders, and you deserve to be whole. So remember, rest is resistance and that joy is liberation. Find the things that bring you joy in your life and do them and practice them every day. Again, it will not be sustained if you don't. So if no one's told you this today, you deserve to be paid well. We've all said it. We all touched and agreed. You deserve to be protected from harm. You deserve to grow. You deserve to rest. And you deserve to heal. Because you're not just a worker in the movement. You are the movement.
Come on.
All right. For time's sake, we're going to skip our sharing a little bit. But there's always time to be able to do that in our communities. So again, if you've met someone new today, exchange information. Don't stay isolated in just your organizations. Get to know who's out there. There's so much crossover sometimes within services, from FIT to therapeutic behavioral services to FSPs. Those services cross over and our agencies cross lines, and our families shouldn't have to feel like they need to belong in a bubble. So talk with each other and make sure we create strong networks of support. All right. So as we're closing our time, and I want to leave time for some questions again, we are rising, y'all. We are rising, not just as peer leaders, but as strategists, as leaders, as advocates, and as healers. Every family you've sat with or will sit with, every crisis you've had to de-escalate or will de-escalate in the future, every time you've said you're not alone, you have changed lives. You've built trust and you've shifted systems. Y'all did that, all right? So give yourselves a round of applause. So as we carry this work forward, these are just the reminders. This is actually just what we talked about in this last hour. Don't forget to honor yourself. Honor your lived experience. Make sure that peers, our voices are included and centered at every decision. Ask good questions. Disrupt systems. I'm getting the 5-minute warning. All right. Champion justice. Make sure equity is not just an optional thing. Think about the ways that you've been held. Think about the ways that you want to lead, and think about the work that lies ahead of you in your own personal journey and in your journeys in the community. And then nurture your own healing. It's our responsibility to do though. So as you're walking out of the room today, I hope you feel your roots and the collective work that's happened today. And I hope you rise with purpose and community by your side. Thank you. I know I'm like 3 minutes between your raffles and the closing. Is there any questions before we close out? Any questions before we close out?
Can we get autographs and photos?
Stop it. Doing this with y'all. No? All right. I'm not seeing anything. I think they're like, I'm not asking a question because I'm ready to win a cup and a comforter and lots of stuff. All right. Thank you. All right, are we awake? We're all awake. Okay.
Jenny, some of you may know Jenny. Jenny has worked in Sacramento County for a very long time. And she is our peer support specialist liaison representing parents and caregivers. So very knowledgeable in the children's system. Has also been on our local alcohol and drug board for very, very many years. Has a whole story of a lot of things. And Jenny, let me tell you, she can hustle because Jenny was able to get all of these raffle prizes donated. Jenny went door to door. Jenny called places. Jenny called them back 20 times, and they all for you. So we appreciate your persistence, and I'm very uncomfortable asking for things, so I'm very grateful that I have Jenny on my team to make this all possible. So we do want to thank the various companies who made donations, and I'm briefly going to try to tell you what we got if I remember. There's a $50 Bennett's. Anybody know Bennett's? Yeah. Kind of bougie. Yeah, so we got a $50 gift card. We got a Buckhorn gift card.
Two of them, $50.
Passes to the Proctor Art Museum. Passes to the Sac Republic game.
Line tickets.
Chipotle gift cards. Coonies. Safeway, Smashburger, Save Mart, Starbucks donated all the cups you've seen. We got the Comforters from Burlington, Good 360 donated some water filters, and then Sports Clips is who provided those haircut vouchers in your bag. So we just want to shout that out real quick. And then we're going to start raffling. Your raffle ticket's in the back of your badge. So pull that up, take a look. Mine's backwards, so I can't see it.
You don't get it.
I don't get it. And
I'll pick, and then I'll read it off. We also want to take a picture, if you're willing, with you and your prize. So,
and you get to pick your prize. So if you're not sure what it is, you're gonna look at Jenny confused, and she's gonna tell you.
Yeah. Okay. The first number is 820-805. 820-805. Come on up. All right, next one, 820-898. Yay! Look at this. Our next one, 820-811. 820-811.
5, 4, 3, 2. All right. Really dig down.
I know you're gonna think that they're all like 820, but that's the part what we used. So 820-862. 820-862. 5, 4, 3, 2, 1. All right. 820-716. 820-716. 5, 4, 3, 2. All right. All right. 820-697.
Oh, that's me.
Woo! 820-760. 820-760. 5, 4, 3, 2, 1. I hate running around. All right. 820-890. We got one right there. Right on. 820-690. Eight 820-889. 820-718. 820-718.
820-718. 5, 4, 3, 2, and 1. 820-903. 820-903. 5, 4, 3, 2, 1. 820-896. 820-885. Oh, Eight two zero 777. Right. 820-902. 820-902. 5, 4, 3, 2, 1. 820-897. 820. All right, we're the winner. More people coming up. You gotta make a choice. 820-849. There we go. Another winner. See, the longer you take to choose, the more competition, right? 820-696. 820-696. Okay, we're gonna take a quick pause while that line goes down, just so we know how many more prizes we have left. In the meantime, in the back of your conference program, I don't have it up here, there's a QR code for the evaluation. On your table, there are also little cards with the QR code for your evaluation. Those are really important for us. We made quite a few changes for this year based on the feedback that we got from everybody. The good, the bad, the ugly, we want to hear it all, because it just helps us to do a better job next year. So please complete your evaluation. It is on the back page. There's a nice little QR code. If you need a paper evaluation, please raise your hand, and I'm going to have a runner. I'm going to have a runner hand out any paper evaluations. Does anybody prefer to fill one out by hand? You're saving us a lot of time. I appreciate it. Five more to go. 5 more prizes. 820-685. 820-685. Yes, there we go. Winner. 4 more prizes. Ooh, we'll win. 820-892. 820-892. 5, 4, 3, 2, and 1. 820-752. 8. Down there. Right on, Ruby. So we're down to what, 3 prizes?
We have 4.
3 because we have another one coming up.
Oh, okay.
All right. 820-836. 820-836. 5, 4, 3, 2, and 1. 820-725. 820-725. 5, 4, 3, 2, 1. 820-866. Yes! Woo! All right. 2 more prizes? 820-8
804. Yes.
Yeah.
All right, for the last prize, 820-719. Oh, you were one off. Hey! Thank you.
All right, so reminders. Complete your evaluation. Don't forget your raffle prize if you got one. You don't need to pay for parking. And I hope you come to our Learning Collaborative next Friday. Y'all have been great. This has been a good day. Everything I think went smoothly. I'll find out in the evaluations. But we thank you for your time. We hope you have a great weekend. And we'll hang out in case anybody needs anything.
My bad. I wasn't picking. I was just
Part of the team.
Oh, you did great. Thank you so much.